Dr. Preeta PP, DHS, and Dr. Kala Keshavan, Principal Government Medical College, Thiruvananthapuram, to occupy the dais. I request the audience to rise for the Khas anthem.
जीवन 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 अमूल्यमानदिनस्तित्वम् अज्ञातमानदिनाधारम् आनन्दमपारमल्भुतकरमाणतिम्बिगस्वरवैविध्यम् नाडीस्पन्दनताळं ताळं हृदयमिडिप्पिन् स्वररागम् ഇരുട്ടകന്നൊരു ശാസ്ത്രയുഗത്തിൻ കരങ്ങൾ മീട്ടിയ സംഗീതം മനോജ്ഞ വിസ്മയമാഗാനത്തിന് ശ്രുതി നീട്ടുന്നവരീനങ്ങൾ തിരിനീട്ടുന്നവരീനങ്ങൾ പ്രപഞ്ച ചേതന വസുന്ധരയ്ക്കായി കനിഞ്ഞു നൽകിയ സമ്മാനം ഓരോ പ്രാണതലങ്ങളിലെഴുതിയ നിഗൂഢമന്ത്രരഹസ്യങ്ങൾ തിരിച്ചറിഞ്ഞൊരു ശാസ്ത്രമിതെന്നും തലോടി മാറ്റും വേദനകൾ നിതാന്ത ജാഗ്രതയോടരികത്തായി കാവൽ നിൽക്കുന്നവർ ഞങ്ങൾ കൂടെ നിൽക്കുന്നവർ ഞങ്ങൾ സർവേ ഭവന്തു സുഖിനാ സർവേ ഭവന്തു സുഖിനാ സർവേ ഭവന്തു സുഖിനാ.
Now, I invite Dr. K. Rajamohanan, Professor in Charge, School of Public Health, for the welcome speech.
A very warm good morning to all. Most respected and beloved Honorable Minister for Health, our dear and respected Asha Thomas Secretary, our dearmost DME Principal, the great scientists who have been invited and willing to spare some time in the midst of their very busy schedule, Dr. Manoj Murghakar, who is actually the Deputy Director of ICMR, Dr. Pratap Tarian and Sri Kumaran Nair, they are just on the way. And our own in-house scientists, Ramgutti sir, Dr. Thangappan, all other teachers, Narendra sir, and my most beloved colleagues and other dignitaries from university, the deans and other close cabinet officers, my dear friends and students. It is a very precious moment for us, proud, and also a lot of uncertainties because today morning I was continuously answering to the calls if there any change in program like that. And they all had a lot of sufferings on travel, I hope. And in spite of all those sufferings, they reached here. That shows their commitment and passion to research and popularization of knowledge base for practice. That is evidence. So thank you all. Thank you, madam. Thank you, madam, for coming. We owe to you a lot for all your hard work and support to us. And because the profession is really in strides after the COVID, and the knowledge base is the most important thing, and we are all committed to that. And our Madam Secretary also, because he is an insider, he is not an outsider for us. Thank you all. Once again, I won't take time. Thank you all. I welcome all of you for this program. This is an academic activity, only, nothing else. All other things, you please bear with us. We are interested only in the academic activities. So the knowledge base is the most important thing. We are all teachers. So we have to be after knowledge. Thank you very much. Thank you and most welcome.
So I welcome our Honorable Minister, Srimati Veena George. And Chair Dr. Mohanan Kundumal. Dr. Asha Thomas IAS, Dr. Thomas Matthew, and Dr. Kalakeshavan. As a Japanese proverb says, better than 1,000 days of diligent study is one day with a great teacher. And he is a true leader who has the confidence to stand alone, courage to make decisions, and compassion to listen to the words of others. And we have Honorable VC, Dr. Professor Mohanan Kundumal with us, and I invite you, sir, for the presidential address.
Chief guest of today's function, Honorable Minister Srimati Veena George, the keynote address invitee, Dr. Asha Thomas, the Additional Chief Secretary of Health, Director of Medical Education, Dr. Thomas Matthew, Principal, Dr. Kalakeshavan, and Head of School of Public Health, Dr. Raj Mohan. Kerala University of Health Sciences is extremely happy and proud to organize the National Clinical Epidemiologists Meet and Workshops in Trivandrum Medical College, which is celebrating its 70th anniversary. This is the first medical college of the state, and therefore we are extremely proud to have this program in this very hall where I also started my MBBS career. Kerala University of Health Sciences, of course, is a young university of 11-year age, but within that short period, we could establish a name as one of the better health universities in the country in terms of its academic program and the quality of the graduates. And the first medical college in Kerala, Trivandrum Medical College, has got an international repute. It has produced great doctors and great researchers who are doing research outside this medical college. But unfortunately, medical colleges in Kerala and the young university does not have a big name in the field of research. This is a reality. And therefore, we have been doing various attempts to encourage research. And this meeting is part of that endeavor. In fact, small interventions were made. Last Governing Council decided to encourage undergraduate research. We are going to give a small scholarship of 10,000 rupees to undergraduate students for 1,000 students in the university. We have got 3 lakh students, but this is a small intervention. Now, again, we are going to conduct research methodology classes for undergraduate students. Now, with the COVID and now we know the online education system, it's extremely useful. Now we are going to introduce that. The course material and everything is ready. Now, postgraduates in various institutions are publishing, and the faculty are also publishing. In order to encourage them, in order to support them, publish articles by the university teachers, we will be giving them cash prize, which also has been decided. Now, the university has got a School of Public Health right in Trivandrum, which is organizing this program, and a standalone building is coming up, which will be inaugurated within a year. And Ayurveda, definitely Kerala has got a great name, but not big research is happening in Ayurveda. So we have a center, a school of fundamental research in Ayurveda in Tripunithara, and many research programs are being done there under Professor Sudhikumar. And a recently launched School of Family Health in Calicut. That building also is coming up, and it will be ready for inauguration, I hope, by the end of this year. And a lot of research in that area we are planning. So these are all the small interventions we are trying to do in order to encourage research among our affiliated colleges. And Kerala government is supporting us in a very huge way, in the sense that a translational research center has been proposed, and we hope that it will be awarded soon in the Kerala University of Health Sciences. 20 crore has been earmarked in the last year's budget. And once that comes through, we will have a excellent translational research center within the university campus in Thrissur. We are collaborating with various other universities, including Veterinary University. Veterinary University is establishing a center of excellence in One Health. And there, the Kerala University is a partner. So together, veterinary, agriculture, forestry, and these universities, I hope we will be able to deal with the various zoonotic diseases which we are facing, including COVID. So this is one area university is going to focus in a big way. And the Translational Research Center, we propose to do research on non-communicable diseases, aging, and these are all the biggest problems, challenges the state is facing. So this meeting is really intended to improve the research and the attitude to do research among the undergraduates and postgraduates. In fact, there have been various opinions said by experts. Why India is behind in research when compared to the rest of the world is that after independence, several standalone research institutions were created in India. And they are not connected with the universities. They are not connected with the colleges. We have extremely good standalone research centers where research is happening. And we have got educational institutions where there is no funding. There is no culture of research. And so the researchers are disconnected with the students in the colleges. This is a reality. And this disconnect can be solved if research is directly funded to the universities, and universities should become research centers. Then and only the undergraduate students and the postgraduate students will realize what is research and what is the culture of research, and they will, many of them will go into research, some of them will go to clinical practice. So this is what is happening in many other countries. Of course, there are other reasons like lack of funding and many other things are there. So we are trying to bridge this gap, and we hope with the help of government, especially there is a great help coming from our Honorable Chief Minister and Health Minister, and with this help, we will be able to bridge this gap, and Kerala University of Health Sciences can become one of the best research institutions in the country, if not the world. Thank you.
Thank you, sir. We feel so proud and privileged to have with us Srimati Veena George, Honorable Minister for Health and Family Welfare, also carrying the portfolio of Medical Education, Medical University, Indigenous Medicine, Ayush, Drug Control and Women and Health Child Welfare. With deep appreciation and great respect, I invite Honorable Minister Srimati Veena George to inaugurate the National Clinical Epidemiologist Meet and Workshop by lighting the lamp and for the inaugural address.
ഗുഡ് മോർണിംഗ്. എല്ലാവർക്കും നമസ്കാരം. ബഹുമാന്യനായ യോഗാധ്യക്ഷൻ, കുഹാസിൻ്റെ വൈസ് ചാൻസലർ ഡോക്ടർ മോഹനൻ കുന്നുമ്മൽ, ഏറ്റവും ബഹുമാനിയായ അഡീഷണൽ ചീഫ് സെക്രട്ടറി മെഡിക്കൽ എഡ്യൂക്കേഷൻ ഡോക്ടർ ആശ തോമസ് IAS, ബഹുമാന്യനായിട്ടുള്ള DME ഡോക്ടർ തോമസ് മാത്യു, ബഹുമാന്യനായിട്ടുള്ള ഡോക്ടർ രാജ്മോഹൻ, തിരുവനന്തപുരം ഗവൺമെൻറ് മെഡിക്കൽ കോളേജിൻ്റെ പ്രിൻസിപ്പൽ ഡോക്ടർ കലാകേശവൻ, ബഹുമാന്യരായിട്ടുള്ള ഡോക്ടർ V രാമൻകുട്ടി, ഡോക്ടർ മനോജ് മുർഹേക്കർ, ഡോക്ടർ പ്രതാപ് തരിയൻ, ഇവിടെ സന്നിഹിതരായിരിക്കുന്ന വിശിഷ്ട അതിഥികളെ, നമ്മുടെ വിവിധ മെഡിക്കൽ കോളേജുകളുടെ പ്രിൻസിപ്പൽമാർ ഉൾപ്പെടെയുള്ള പ്രിയപ്പെട്ട ഡോക്ടേഴ്സ്, പ്രിയ സഹപ്രവർത്തകരെ, സഹോദരി സഹോദരന്മാരെ, പ്രതികൂല സാഹചര്യങ്ങൾക്കിടയിലും നമ്മൾ മുൻപ് നിശ്ചയിച്ച കേരള യൂണിവേഴ്സിറ്റി ഓഫ് ഹെൽത്ത് സയൻസസിൻ്റെ സ്കൂൾ ഓഫ് പബ്ലിക് ഹെൽത്തിൻ്റെ ആഭിമുഖ്യത്തിൽ ഇവിടെ സംഘടിപ്പിക്കപ്പെടുന്ന ഈ വർക്ക്ഷോപ്പ് മാറ്റമില്ലാതെ നടത്തുന്നതിനും അതോടൊപ്പം തന്നെ ഇതിലേക്ക് എത്തുന്നതിനും ശ്രമിച്ച എല്ലാവരെയും ഹൃദയപൂർവ്വം അഭിനന്ദിക്കുകയാണ്. ഞാൻ നമ്മുടെ രാജ്യം കണ്ട അല്ലെങ്കിൽ കേരളം കണ്ട ഏറ്റവും പ്രഗത്ഭനായിട്ടുള്ള ഒരു പ്രഭാഷകനാണ് സുകുമാർ അഴീക്കോട് മാഷ്. അപ്പോൾ അദ്ദേഹത്തോടൊരു ദിവസം ഒരാൾ ചോദിച്ചു, എന്താണ് മാഷെ ഇങ്ങനെ വളരെ ക്ഷീണിതനായിരിക്കുന്നല്ലോ എന്ന് ചോദിച്ചപ്പോൾ പറഞ്ഞു, ഈ സ്വാഗത പ്രസംഗങ്ങൾ എന്നെ ക്ഷീണിപ്പിച്ചിരിക്കുകയാണ് എന്ന് പറഞ്ഞു. ഞാൻ ഈ അടുത്ത കാലത്ത് കേട്ട വളരെ കാര്യമാത്ര പ്രസക്തമായ മനോഹരമായിട്ടുള്ളൊരു സ്വാഗത പ്രസംഗമായിരുന്നു ഡോക്ടർ രാജ്മോഹൻ്റെ. കാരണം നമ്മൾ ഈ വിശേഷണങ്ങൾ കേൾക്കുമ്പോൾ എന്നെ സംബന്ധിച്ചൊരു ജാള്യമാണ്. ഈ വേദിയിൽ ഇരിക്കുമ്പോൾ അത് ഏത് ഈ അഡ്ജക്റ്റീവ്സ് ചേർത്ത് പറഞ്ഞുകൊണ്ടിരിക്കുമ്പോൾ അതൊരു അസ്വസ്ഥതയാണ്. പക്ഷെ വളരെ മനോഹരമായി അങ്ങ് പറഞ്ഞ എല്ലാ സ്വാഗത പ്രസംഗങ്ങൾ ഒറ്റ വാക്കിൽ മതി, പേര് പോലും പറയേണ്ടതില്ലെന്നാണ് എൻ്റെ പക്ഷം. നന്ദിയും അതുപോലെയാണ്. അപ്പോൾ ഞാനത് പറഞ്ഞു പോയതാണ്. ഏത് ശാഖയെ സംബന്ധിച്ചിടത്തോളം ആ ശാഖയുടെ പുരോഗതിക്ക് ഗവേഷണം അനിവാര്യമാണ്. അല്ലെങ്കിൽ കെട്ടിക്കിടക്കുന്ന ഒരു വെള്ളം പോലെയാണ്, ഒഴുക്കില്ലാത്ത, അകത്തേക്കും പുറത്തേക്കും നീരൊഴുക്കില്ലാത്ത കെട്ടിക്കിടക്കുന്ന, സ്വാഭാവികമായി ആകുന്ന അല്ലെങ്കിൽ അങ്ങനെയുള്ളൊരു ജലാശയം പോലെയാണ് ഗവേഷണമില്ലാത്ത ഏത് ശാസ്ത്രശാഖയും. അങ്ങനെ എക്സിസ്റ്റ് ചെയ്യാൻ ഒരു ശാസ്ത്രശാഖയ്ക്കും കഴിയുകയില്ല. അപ്പോൾ ചികിത്സാ രംഗത്തെ സംബന്ധിച്ചിടത്തോളം, വൈദ്യശാസ്ത്രത്തെ സംബന്ധിച്ചിടത്തോളം ഏറ്റവും പ്രധാനപ്പെട്ട കാര്യമാണ് ഗവേഷണം. കേരളത്തെ സംബന്ധിച്ചിടത്തോളം നമുക്കറിയാം, നമ്മുടെ കേരള ഹെൽത്ത് ബ്രാൻഡഡാണ്. അത് പതിറ്റാണ്ടുകളായിട്ടുള്ള ദീർഘവീക്ഷണത്തോടെയുള്ള, എത്രയോ ഒരു നൂറ്റാണ്ടിനപ്പുറം പഴക്കമുള്ള ദീർഘവീക്ഷണത്തോടെയുള്ള ഭരണാധികാരികളുടെ, രാജ്യം സ്വതന്ത്രമായതിനു ശേഷം, കേരള സംസ്ഥാനം രൂപീകൃതമായതിനു ശേഷം ആദ്യ സർക്കാരിൻ്റെയൊക്കെ വളരെ ധിഷണാപരവും അതുപോലെ ദീർഘവീക്ഷണത്തോടെയുള്ള ഇടപെടലുകളുടെ ഭാഗമായിട്ടാണ് പൊതുജന ആരോഗ്യ രംഗത്ത് നമുക്ക് ഈ ഒരു മികവ് നേടാൻ സാധിച്ചിട്ടുള്ളത്. അപ്പോൾ നമുക്കൊരു സിസ്റ്റമുണ്ട്. ഏത് വെല്ലുവിളി നമ്മൾ നേരിടുമ്പോഴും, അത് കോവിഡ് ആണെങ്കിലും നിപ്പയാണെങ്കിലും, നമ്മളൊരു സിസ്റ്റം ഇവോൾവ് ചെയ്തിട്ടുണ്ട്. അപ്പോൾ ആ ഒരു സിസ്റ്റത്തിലൂടെയാണ് നമ്മൾ ഈ ചാലഞ്ചസിനെ എല്ലാം നേരിടുന്നത്. ആ കേരള ഹെൽത്ത് ആ രീതിയിൽ ബ്രാൻഡഡ് ആയിരിക്കുമ്പോഴും, അപ്പോൾ നമ്മുടെ ആളുകൾ, നമ്മുടെ പ്രൊഫഷണൽസ് അല്ലെങ്കിൽ നമ്മുടെ ഡോക്ടേഴ്സും മറ്റ് ആരോഗ്യ മേഖലയിലുള്ള പ്രഗത്ഭരായിട്ടുള്ള ആളുകൾ ആഗോളതലത്തിൽ തന്നെ എല്ലാ മേഖലകളിലും പല യൂണിവേഴ്സിറ്റികളിലും പോയി വലിയ രീതിയിൽ പ്രതിഭാധനരായി അവർ പ്രവർത്തിക്കുന്നുണ്ട്. ഞാൻ നമ്മുടെ സംസ്ഥാനത്തുള്ള പല ഡോക്ടേഴ്സിനോടും ഒക്കെ സംസാരിക്കുമ്പോൾ വളരെ അക്കാഡമിക് ബ്രില്യൻസ് ഉള്ള ഒരുപാട് ആളുകൾ നമ്മുടെ ഇടയിലുണ്ട്. അപ്പോൾ ഇതിനെ നമ്മുടെ ആരോഗ്യ മേഖലയ്ക്കും അതുപോലെ വൈദ്യശാസ്ത്ര രംഗത്തിനും ഗുണപരമായ രീതിയിൽ ഉപയോഗപ്പെടുത്തുക എന്ന വാക്ക് ശരിയല്ലെന്ന് എനിക്കറിയാം. യൂട്ടിലൈസേഷൻ എന്നുള്ളതല്ല ശരി. ഞാനതിൻ്റെ നല്ല അർത്ഥത്തിലാണ് പറഞ്ഞത്. അപ്പോൾ ആ രീതിയിലേക്ക് അത് പരിവർത്തനപ്പെടുത്തുക എന്നുള്ളത് വളരെ പ്രധാനപ്പെട്ട ഒരു കാര്യമാണെന്നാണ് ഞാൻ കരുതുന്നത്. അതുകൊണ്ടാണ് ഈ സർക്കാരിൻ്റെ കാലയളവിൽ, പ്രത്യേകിച്ച് ഈ സർക്കാരിൻ്റെ ഒരു നയത്തിൻ്റെ ഏറ്റവും ബേസിക് ആയിട്ടുള്ള ഒരു കാര്യം നമ്മുടെ ഹയർ എഡ്യൂക്കേഷൻ, ഉന്നത വിദ്യാഭ്യാസ രംഗത്തെ പ്രോത്സാഹിപ്പിക്കുക എന്നുള്ളതാണ്. ഉന്നത വിദ്യാഭ്യാസ രംഗം എന്ന് പറയുമ്പോൾ അതിലെ ഒരു ഏറ്റവും പ്രധാനപ്പെട്ട ഒരു ഘടകമാണ് മെഡിക്കൽ എഡ്യൂക്കേഷൻ. അപ്പോൾ മെഡിക്കൽ എഡ്യൂക്കേഷനിൽ ഉൾപ്പെടെ ഗവേഷണം പ്രോത്സാഹിപ്പിക്കുക എന്നുള്ളത് നമ്മുടെ ഒരു ലക്ഷ്യമാണ്. അപ്പോൾ കുറേ ഗ്യാപ്പുകൾ എക്സിസ്റ്റ് ചെയ്യുന്നുണ്ട്. ഇപ്പോൾ ഇവിടെ ബഹുമാന്യനായിട്ടുള്ള BC പറഞ്ഞു, നമ്മുടെ അണ്ടർ ഗ്രാജുവേറ്റ്സിലും ഗ്രാജുവേറ്റ്സിലും ഒക്കെയുള്ള ഗവേഷണ താല്പര്യത്തെ പ്രോത്സാഹിപ്പിക്കുക അല്ലെങ്കിൽ അത് ഉണ്ടാക്കുക എന്നുള്ളത്. അതോടൊപ്പം തന്നെ വളരെ പ്രധാനപ്പെട്ട നമ്മുടെ ഫാക്കൾട്ടീസ്, അധ്യാപകർക്കിടയിലുള്ള ആ രീതിയിലുള്ള ഗവേഷണം പ്രോത്സാഹിപ്പിക്കുക എന്നുള്ളതും വളരെ പ്രധാനപ്പെട്ടതാണ്. അദ്ദേഹം ഇവിടെ സൂചിപ്പിച്ചു, ബഹുമാന്യനായ VC സൂചിപ്പിച്ചു, ഈ കഴിഞ്ഞ ബജറ്റിൽ നമുക്ക് ട്രാൻസ്ലേഷണൽ റിസർച്ചിന് 20 കോടി രൂപ, എല്ലാ യൂണിവേഴ്സിറ്റികൾക്കും 20 കോടി രൂപ വീതമുണ്ട്. ഞാൻ മനസ്സിലാക്കുന്നത് നമ്മുടെ അക്കാഡമിക് റിസർച്ചും അതുപോലെ ക്ലിനിക്കൽ റിസർച്ചും തമ്മിലുള്ള ഗ്യാപ്പ് അത് ബ്രിഡ്ജ് ചെയ്യുന്നതാണ് ട്രാൻസ്ലേഷണൽ റിസർച്ച് എന്നാണ് ഞാൻ മനസ്സിലാക്കുന്നത്. വളരെ ആവശ്യമാണ്. അപ്പോൾ അതുൾപ്പെടെയുള്ള എല്ലാ മേഖലകളിലും നമുക്ക് ഗവേഷണം അനിവാര്യമാണ് എന്നുള്ളത് നമുക്ക് മുന്നിലുള്ള ഡേറ്റ വളരെ വൈവിധ്യമാർന്ന ഡേറ്റയാണ്. ഇങ്ങനെ ഒരു ഡേറ്റ മറ്റ് സ്ഥലങ്ങളിൽ അല്ലെങ്കിൽ മറ്റ് സംസ്ഥാനങ്ങളിൽ അതിൻ്റെ ഡോക്യുമെൻറ്റേഷനും പ്രോപ്പറായിട്ട് ഏതാണ്ടെന്നല്ല നല്ല രീതിയിൽ തന്നെ ഡോക്യുമെൻറ്റേഷൻ നടക്കുന്ന ഒരു സംസ്ഥാനമാണ് കേരളം. അപ്പോൾ ഇത് വ്യക്തിപരമായി അവരവരുടെ ഒരു അക്കാഡമിക് പ്രതിഭയെ മുന്നോട്ട് കൊണ്ടുപോകുന്നതിനും അതോടൊപ്പം തന്നെ നമ്മുടെ ആരോഗ്യ മേഖലയെ മുന്നോട്ട് കൊണ്ടുപോകുന്നതിനും രാജ്യത്തിനും സംസ്ഥാനത്തിനും മാത്രമല്ല രാജ്യത്തിനും ആ കോൺട്രിബ്യൂഷൻസ് നൽകുന്നതിനു വേണ്ടി അത് അനിവാര്യമാണ് എന്നുള്ളത് കാണുകയാണ്. ഞാൻ കേരള യൂണിവേഴ്സിറ്റി ഓഫ് ഹെൽത്ത് സയൻസസിനെ ഹൃദയപൂർവ്വം അഭിനന്ദിക്കുന്നു. ഈ ഒരു രീതിയിൽ ഒരു വർക്ക്ഷോപ്പ് സംഘടിപ്പിച്ചതിന്. ഇത് ഒരു തുടർ പ്രക്രിയ ആകും എന്ന് ഞാൻ കരുതുകയാണ്. അതുപോലെ എമിനൻ്റ് ആയിട്ടുള്ള പ്രഭാഷകരാണ് നമുക്കിന്ന് ഇവിടെ വന്ന് നമ്മളോട് സംസാരിക്കുന്നത് എന്നുള്ളതും നല്ല സന്തോഷമുള്ള ഒരു കാര്യമാണ്. ഇതിനിടയിൽ നമ്മുടെ ഒരു കോവിഡ് കാലത്തെ എക്സ്പീരിയൻസസിൻ്റെയും അനുഭവങ്ങളുടെ ഒരു നേർസാക്ഷ്യം അതും ഡോക്യുമെൻ്റ് ചെയ്യപ്പെട്ടിട്ടുണ്ടെന്ന് കരുതുന്നില്ലേ, അത് നമ്മളിവിടെ എക്സിബിറ്റ് ചെയ്യുന്നുണ്ട്. ഓക്കെ, അപ്പോൾ അതിലും എല്ലാവിധമായിട്ടുള്ള അഭിനന്ദനങ്ങളും. നമുക്കൊരു സർക്കാർ തലത്തിലൊരു ഡോക്യുമെൻറ്റേഷൻ കോവിഡിന് നമ്മൾ ആരംഭിച്ചിട്ടുണ്ട്. അത് നമുക്ക് മാത്രമല്ല വരും തലമുറകൾക്കും അത് പ്രയോജനകരമാണ്. ഡോക്യുമെൻറ്റേഷൻ ഇൻ ദ സെൻസ് അതിൻ്റെ ചർച്ച ആരംഭിച്ചിട്ടുണ്ട്. അത് പൂർണ്ണതോതിൽ നമുക്കുണ്ട്. അതിനെ ഒരു ഡോക്യുമെൻ്റ് ആക്കുന്നതിന് വേണ്ടിയിട്ടുള്ള പ്രവർത്തനങ്ങൾ ആ രീതിയിലേക്ക് നമുക്ക് ആലോചിച്ചിട്ടുണ്ട് എന്നുള്ളതാണ്. ഞാൻ വാക്കുകൾ ദീർഘിപ്പിക്കുന്നില്ല. എല്ലാ ആശംസകളും. നിങ്ങളുടെ ഓരോരുത്തരുടെയും ഉള്ളിലുള്ള ഗവേഷണ ത്വരയെ ആണ് നിങ്ങളെ ഈ ദിവസം ഇവിടെ എത്തിച്ചിരിക്കുന്നത് എന്നുള്ളതാണ് ഞാൻ മനസ്സിലാക്കുന്നത്. അതിനെ ഞാൻ ഏറ്റവും ആദരവോടുകൂടി കാണുന്നു. അത് നിശ്ചയമായിട്ട് നമ്മുടെ ആരോഗ്യ മേഖലയിലെ ഗവേഷണ രംഗത്തെ മുന്നോട്ട് നയിക്കും എന്നാണ് ഞാൻ പൂർണ്ണമായി വിശ്വസിക്കുന്നത്. ഗവൺമെൻറ്റിൻ്റെയും ആരോഗ്യ വകുപ്പിൻ്റെയും എല്ലാവിധമായിട്ടുള്ള പിന്തുണയും. ഞാൻ ഇവിടെ വെച്ച് തന്നെ നമ്മുടെ അലംനായി പൂർവ്വ വിദ്യാർത്ഥികളുടെയൊക്കെ നേതൃത്വത്തിൽ ഒരു ഗവേഷണം സംബന്ധിച്ചിട്ടുള്ളൊരു സെമിനാർ വർക്ക്ഷോപ്പ് നടന്നപ്പോൾ യങ് റിസർച്ചേഴ്സിന് നമ്മൾ സപ്പോർട്ട് ചെയ്യാം എന്ന് പറഞ്ഞിരുന്നു. അതോടൊപ്പം തന്നെ നമുക്ക് എന്തൊക്കെ കാര്യങ്ങൾ ഗവൺമെൻറ്റിന് ചെയ്യാൻ കഴിയും എന്നുള്ളതിൽ അതിൽ പൂർണ്ണമായ പിന്തുണ നിശ്ചയമായിട്ടും ഉണ്ടാകുമെന്ന് മാത്രം പറഞ്ഞുകൊണ്ട് ഔപചാരികമായി എല്ലാവരോടും ഉള്ള ആദരവും അറിയിച്ചുകൊണ്ട് ഔപചാരികമായി ഉദ്ഘാടനം നിർവഹിക്കുന്നതായി അറിയിച്ചുകൊള്ളുന്നു. നന്ദി, നമസ്കാരം.
Thank you very much for your words of wisdom. School of Public Health has prepared a document on COVID experience of Kerala. I request the Honorable Minister to release the document. I also request Honorable VC to hand over the document to the Minister. Thank you, Madam. Now, I invite Dr. Asha Thomas, IAS, Additional Chief Secretary, Health and Family Welfare Department, Kerala, for the keynote address.
Good morning. My greetings to all distinguished persons on the dais. Srimati Veena George, Honorable Minister for Health, Dr. Mohan Kundumal, Honorable Vice Chancellor of the Kerala University, Dr. Thomas Matthew, DME, Dr. Kalakeshwan Principal, Dr. Raj Mohan. Even though I'm not naming everybody by name, my greetings to all the people in the audience, especially the people who have come here as speakers on the occasion. I am taking the liberty of speaking to you in English because I am not that familiar with speaking in Malayalam the way the speakers before me were able to. I commend the VC, Dr. Mohanan, for organizing this seminar around a very important topic. as the Honorable Minister just mentioned, we have been discussing the need of encouraging research in our medical colleges for a while now, though we haven't gone ahead with operationalizing those suggestions as fast as we should have done. There has been some mention about the fact that we don't have a research culture in our colleges. That is absolutely true, and we know it. We see research as a niche activity, something that a very few people who might be interested in it, but most of us do it as an activity we have to do for the sake of our promotions or for a certain career move. We don't even understand research as part of our daily life. Yet we always deal with research. Suppose you want to buy a new car, what do? You go out, you ask your friends, you ask for recommendations, you read up about the latest models in a car magazine, you check out the local showroom, you ask the guy there for recommendations and advice, and finally you collate all the information you got, you make a cost-benefit analysis. Does the happiness involved in showing off this car at the next get-together of your colleagues, does it outweigh your seriously reduced bank balance? And finally, you come to a conclusion. And if you ultimately go out and buy the car, well, you have done translational research. So, but this is obviously not scientific research. Obviously, we cannot use this sort of anecdotal evidence to make decisions for other people in society. We who are in positions of influence over other people's lives, we have to be careful with what data we use for our decision making and how we translate that into practice. So why is it that we are still talking about research? Why do we doctors still have to be educated about research? India does not have a broad research base. Just now, I think Dr. Rajmohan was speaking about the fact that Dr. Kundamal was talking about the fact that we do have a few institutions which do research, standalone institutions, and they are among the best in the world. But as a broad base, we have not valued research. In our schools, in fact, even before that, when we raise our children, we do not encourage them to find out anything on their own. We feed them information. In our schools, we don't expect students to learn anything on their own. We encourage them for memorizing and spitting it out. In fact, if a student writes an answer in an exam which is different from what is in the textbook or in the notes, he's penalized for it. So in a culture like this, we don't really encourage independent thinking, let alone research. And suddenly, in fact, this goes on all the way up to college level. And suddenly they come to a medical college or they get to a PG course and we expect them to do research. There was a perspective paper of the planning board which mentioned that most of what we do as research is just a glorified audit. I have seen many of the papers which are published by faculty here in the name of published papers. Do you know how many of them are just case reviews? In fact, you can now publish a paper on a single case, descriptive case study, single case. And even that is considered acceptable. Well, I'm sure it is acceptable in certain circumstances, but when we talk of research, as Dr. Ramankuti was mentioning earlier, how would it be, what directs that research? Is it is it based on something which we have seen as possibly irrelevant? Can it be translated? Can it be scaled up? So, in my short time in the health department, I have been struck with another thing. The quality of the proposals for policy that is brought to the government. They are almost all of them not backed by data, not provided with proper justification, which inevitably means that somebody like me sitting there and looking at this will raise questions. And I've often found that everybody is very surprised that why am I asking questions? Why don't I just accept it and move on? It is seen as a block for an administrator to question a proposal or a conclusion that a doctor might bring as an intervention or as a policy. It is important that with that same attitude, Dr. Ramamurthy was raising a very relevant point in that last question. He was saying that policymakers start from the conclusion and work backwards. That is so true, but then sometimes they do work backwards. They do ask, how did you arrive at this conclusion? How can you prove that this will work? And at that time, you should be prepared to justify those conclusions. So you can't really translate a conclusion into policy without doing some work in justifying that. And perhaps the School of Translational Research will get to that point that we will finally get possible policy that we can implement right away. Another important thing that we should consider is that we should be able to list and document all the research, all the publications that we do in one place so that we can know what we have done. Right now, if I want to find out if anything has been done in a particular field in our state, there is nowhere I can go and find it out. At least whatever has come out of our medical colleges should be listed and archived in one place, and with, so that you can search by topic and get it. Let me think, is there anything else that I wanted to say to you? Yes, by the way, we are now going into e-health as a hospital management information system. I am sure you're all aware of this because we are implementing it in our colleges. I urge you all to reflect on what this means for the state. This means that suddenly huge amounts of patient data are now being kept somewhere. And it's being collected and it's stored. I urge you to reflect on what this means in terms of research, who gets accessibility to this data, how do we protect the patient data. There is a tendency within our medical colleges to assume that this is something is imposed on you. Please do not see it that way. This is something you have to be involved with, and there's something you should be able to use also towards research, towards improving your own work, your own patient care methods. The president of AKMG, Dr. Nijal Haroon, was once mentioning to me that there are places in the United States, UK, there's an agency which actually controls the patient data and is selling it to researchers for a fee. Anonymized data, controlled data, but they're actually going ahead and selling this. What that means is that we also should be thinking that way. We have spent over 100 crores already in bringing in e-health. We should realize that this data has value. When we talk about translational research in technology interventions, we should always ask ourselves whether we are satisfactorily managing and regulating our data, whether we are protecting our data in a way that we should be doing. I hope the School of Translational Research will also take in these facts into consideration as they go forward. And finally, the only other thing that I wish to say is that, once again, going back to the reasons we do research, there was mention earlier about the fact that internationally they build up a research culture. One of the reasons that I flatly know in practice is that in a university in the US, if you do not publish, you will perish. You will be fired if you do not come up with a certain amount of research of a certain quality. We are not asked to do that. So really, we do not, incentive to research is built into that system. We do not have that sort of incentive for research. Of course, it is not that I'm advocating that we should get around to, punishing people for not having turned out a certain level of quality. But it is important that we realize that that is the way it is working in other places. We have not emphasized that in our culture, but I just wanted to leave you with these things to talk about. I am hoping that the School of Translational Research, when it does happen in the university, will take in all these aspects into consideration and help to build up research focus and quality research focus in our state. As the Honorable Minister said, our practice, our work, our knowledge is just a stagnant pool if we do not get knowledge coming in and flowing out to make the world a better place. Thank you.
Thank you, ma'am, for your thought-provoking words. I would like to invite Dr. Thomas Matthew, Director of Medical Education, for the felicitation.
സ്വാഗത പ്രസംഗങ്ങൾ മാത്രമല്ല മാഡം, ആശംസകളും ആളുകളെ തളർത്തും ക്ഷീണിപ്പിക്കും. അതുകൊണ്ടത് നീട്ടുന്നില്ല. ബഹുമാന്യരായ എല്ലാവർക്കും നമസ്കാരം. 3 കാരണങ്ങൾ കൊണ്ടാണ് ആളുകൾ റിസർച്ച് ചെയ്യുന്നത്, എന്തും ചെയ്യുന്നത്. ഒന്ന്, ഡിഫോൾട്ട്. അതിനെപ്പറ്റി എപ്പോഴും നമ്മുടെ ബഹുമാന്യായ മന്ത്രി തന്നെ പരാതി പറയാറുണ്ട്. പ്രൊമോഷന് വേണ്ടി ഉണ്ടാക്കുന്ന പേപ്പറുകൾ. റിസർച്ച് ബൈ ഡിഫോൾട്ട്. റിസർച്ച് ബൈ ഡിസൈൻ, നല്ലൊരു പ്രൊഫഷൻ, ലുക്രേറ്റീവ് സാലറി, എസ്റ്റാബ്ലിഷ്മെൻറ്റ്. മൂന്നാമത്തേത് റിസർച്ച് ബൈ ഡ്രീം ഓർ പാഷൻ. ഈ റൂമിലിരിക്കുന്ന എല്ലാവരും, everyone present in this hall, they are driven to research by passion. So I don't want to talk about the importance of research here, but I want to mention our leaders who are in this hall, who have been taught by Professor Soman sir, starting from Vijaykumar sir, Rajmohan sir, then Ramangutti sir, and their students, Anish, Dr. Seru, all the team, not to mention others, because all of them who are here, they were the people who were instilling the sense of passion among students in medical colleges to take up research as a profession. And they have done their best. I think the whole purpose, we have, as Madam has said, there are a lot of opportunities now for doing research, a lot of topics also to research, and university is very keen. What university should also, like they have said in their starting anthem, they should instill passion for research as the key component for spreading and enhancing research. Because with passion, people will carry on. That here we had, as an institution where we all studied, these teachers have done wonderful work for spreading the message of research and carrying it through. So I think each conference, especially this one, will help to propagate the message of passion in research, and each of us will go back to instill passion and more confidence for research among our students and our colleagues. Thank you very much.
Thank you, sir, for your short and simple message. Now, let me invite Dr. Kalakeshavan P., Principal, Government Medical College, Thiruvananthapuram, to deliver the vote of thanks.
Honorable Minister for Health, Srimati Veena George, our keynote addressee, Dr. Asha Thomas, IAS, chairperson of the session, Dr. Mohan Kundamal, School of Public Health, Chairman Dr. Raj Mohan, Director of Medical Education, Dr. Thomas Matthew, distinguished speakers, my teachers, colleagues, and delegates. Now, as has been said here, there is actually no dearth of research occurring in the institution, but somehow it doesn't get translated into, some are lost in the way. They're not getting published, and they don't make it to policy making level as well. So I wish that, I pray that this 2-day workshop will address these issues, and has been said by the earlier speakers, instill passion in all present here, both physically and virtually. Now, the duty endowed upon me is to propose a vote of thanks. Now, first of all, let me thank our Honorable Minister, Srimati Veena George, for her presence and her valuable message in spite of her busy schedule. Then I thank Dr. Asha Thomas again for thought-provoking message. The chairman of the session, Dr. Mohan Kundamal, he also has raised some valid points which I hope will be addressed. Then our director, Dr. Thomas Matthew, for his felicitations. And then we have distinguished speakers from across the country, from within the state, and then the delegates. Without good delegates, no session will become meaningful. So I thank each and every one of you for your presence and for the encouragement provided. Thank you.
Thank you, ma'am. And now I request all the audience to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. Now we are continuing with our academic session.
ബ്രോഷർ തരാം.
അല്ലല്ല Session. The next speech is on Lesson from COVID Experience, National Scenario. The speaker for the session is Dr. Manoj Murekha, Scientist and Director, NIE ICMR Chennai. And the session will be chaired by Dr. H. Abdul Rashid, Special Officer, DME, Kerala. I request both the speaker and the chair to occupy the dais.
Chairs are not coming.
I request Abdul Rashid sir. Sir, please be on the dais.
Good morning to all. Now I invite Dr. Manoj. He is the director of ICMR, and he is talking about the lessons from COVID experience, national scenario. Over to you, sir.
Thank you very much. And at the outset, I want to thank Professor Rajmohan sir, my elder brother, for inviting me to talk in this symposium. Well, as you all know, COVID has been described as one of the lifetime pandemics. And although about 10 days back, WHO chief mentioned that the end is in sight, the emergencies, public health emergencies like COVID are going to strike us in coming days. And therefore, I'm going to talk about some of the lessons that can be learned from COVID experience. I'll primarily focusing on the experience at a national level. And I'll be talking on these three major topics. One is briefly talk about COVID scenario in the last 2.5 years. Briefly touch upon the response activities for COVID pandemic, and then talk about the key lessons. Well, this slide describes the number of COVID cases and deaths in India. And the left-hand side graph shows India had 3 waves of COVID-19 with more than 4.45 crore cases. The first wave was primarily due to the ancestral Wuhan strain. And at the peak of the first wave, we had nearly 100,000 cases per day reported from the country. The second wave was mainly because of highly infectious Delta variant. The second wave was much taller than the first wave, and also had a large mortality because of COVID during the second wave. The third wave was very short wave, but the number of cases were much higher than the first wave, which was mainly driven by Omicron and its lineages. As per the official records, about 528,000 deaths have been reported from India. And again, like the curve for cases, there were 3 peaks. But there are several reports, several studies which have reported that the deaths in India were much more underreported. And this is one study which got recently published in Lancet from the IHME group, which talks about excess mortality because of COVID in India. So as you can see here in this graph, based on the reported number of COVID deaths, the reported COVID mortality rate in India was 18 per 100,000 population, whereas the model estimated excess mortality was 152 per 100,000 population. And these red dots basically reflects the ratio between these two rates, the reported rates as well as the model estimated excess mortality rate. And at national level, this ratio was 8. It basically reflects the undercounting of true mortality due to COVID. And it also, this graph also shows the variation of this ratio between states. This ratio was as low as 2 in Kerala and as high as 27 in Bihar. Again, mainly indicating that the deaths were highly undercounted in India. Coming to the infections, SARS-CoV-2 infections, there have been at least 4 national level sero surveys conducted by ICMR, which documented the extent of SARS-CoV-2 infection in the country. At the beginning of pandemic, that is in May 2020, less than 1% of population was infected. At the peak of second wave, first wave, about 7% of population was infected because of SARS-CoV-2. This proportion increased to about 25% at the end of first wave. And at the end of second wave, about 69% of the population had antibodies. There were several other studies conducted in states as well as in major cities which documented the seroprevalence. And a meta-analysis of these studies indicated that at the end of first wave, about 20% of population was infected because of COVID, whereas at the end of second wave, the proportion was 69%. Coming to the vaccination, as we all know, Government of India introduced COVID-19 vaccination in January 2021. And till yesterday, more than 200 crore individuals were vaccinated, or vaccine doses were given. And the right-hand side graph describes the coverage of vaccination, again indicating a very good job done by India in terms of vaccination. Coming now to the national response. On 14th of March 2020, Government of India declared COVID-19 as a notified disaster. And this allowed states to use the State Disaster Relief Fund. Then on 24th of March 2020, India imposed a national lockdown, as we all know. And the strategy for COVID response and COVID control was primarily based on these 3 principles, that is test, track, and treat. There were several expert committees and expert groups which guided and coordinated COVID-19 response. And that included 11 empowered groups, which was constituted by Government of India about 5 days after the lockdown was imposed. And these groups covered several major areas of response, including emergency management, hospital availability, surveillance, medical equipment, and PPE supplies, and so on. ICMR on 18th of March had established a national task force. And this task force had performed several activities, including calibration of testing strategy, advised government on lockdown as well as containment strategy, developed advisories, provided oversight for ongoing research activities, including clinical trials. And in August 2020, Government of India also established one more expert group called NEGVAC, primarily to advise and guide on COVID vaccination, and also decide about priority groups for vaccination. So, as I mentioned, India had imposed a national lockdown when we had less than 500 confirmed cases of COVID-19. And these cases were mainly in big cities like Mumbai, like Chennai, like Delhi. And this lockdown initially was declared for 3 weeks, which was then extended till the 31st of May 2020. And as you can see, the primary objective of this lockdown was to reduce the transmission in the community and thereby reduce the mortality. And more importantly, it was also expected to provide an opportunity to prepare health systems for managing the cases. So as you can see in this graph, during the initial period, the doubling rate of cases was about 2 to 3 days, which increased to more than 5 days as the lockdown was implemented. The case fatality ratio because of COVID also remained low during lockdown, and India also scaled up the testing during this period. But the lockdown also had a negative aspect, and migrants were the worst affected because of this lockdown. And as per the World Bank report, more than 40 million migrants were affected because of lockdown. And also about 50 to 60,000 people migrated from urban areas to rural areas and thereby carried the infection to rural areas. The second important point in response was testing. When the first case of COVID-19 was diagnosed, we had only one lab in the country which provided diagnosis for COVID-19. Later on, ICMR, because it was ICMR's responsibility to establish the testing network in the country, it roped in ICMR's virology labs for testing. Subsequently, the medical colleges as well as S&T labs in the country were roped in for PCR testing. And it was by the end of March 2020, private labs which were NABL accredited were involved in COVID-19 testing. Initial testing was mainly PCR based, and later on TrueNAT as well as CBNAT testing was introduced, and then antigen based tests were introduced. India adopted a very calibrated approach for testing. And in an initial period, the testing was primarily for people who are international travelers and who were symptomatic and their contacts. And it was only in September when testing was opened or was available on demand. And probably on account of our calibrated testing approach, the testing rates in initial period of pandemic were very low. But as the testing capacity as well as testing strategy expanded, India tested nearly 20 or more than 20 lakh cases a day in the peak of second wave. Then these expert groups and expert committees that I mentioned issued several guidelines for COVID response, which were adapted or modified by state governments. And these guidelines were for surveillance, including contact tracing, isolation, quarantine, for containment zones, lockdown and unlockdown, as well as for clinical management and vaccination. Next important activity in the response was genome surveillance. In fact, during the initial part of pandemic, NIV was doing genome surveillance of from patients who initial cases as well as international travelers. But then considering the importance of generating real-time data about the variants that are circulating, India established this genome surveillance consortium. Its main objectives were to assess the circulating variants in the country and also correlate this genome surveillance data with the clinical as well as epidemiological data. Initially, there were only 10 labs which were doing this genome surveillance testing, and currently there are 38 labs which are contributing to the testing. And as you can see in this right-hand side graph, This is the last report that is available on INSACOG website, which pertains to the strains which are circulating in India by July 2022. And most of the strains are of Omicron variant, that is BA2. There have been some issues with respect to genome surveillance, and one important issue is real-time nature of this data. And this was especially evident during the initial phases of Delta wave. And as you can see that Delta variant emerged in Amravati in Maharashtra much earlier before it was actually declared from the country. Also, there are issues with respect to correlation of these variants with clinical as well as epidemiological data. Well, having briefly described about the response, let me talk about some of the important lessons that could be learned from the response. During the COVID pandemic, the health systems of all Indian states and all countries were overwhelmed. And one important lesson that could be learned from COVID-19 experience was to strengthen the health system and make them more resilient. The health systems were overwhelmed primarily because of large number of patients that the health facilities were seeing, the hospitalization and mortality associated with COVID-19 patients. And also, all the health staff were repurposed for COVID-19, and as a result, essential health services were disrupted. And this also led to excess mortality because of non-COVID diseases. And TB is one very pertinent example. The World TB report for 2020 says that there were at least 1 lakh excess deaths because of TB globally. So, first lesson that I think can be learned from COVID-19 is strengthening our health system. And one first important thing in that is strengthening our primary care. And this is also a cornerstone for achieving universal health coverage. Government of India's ambitious plan of establishing 150,000 health and wellness center for providing comprehensive care is a right step in this direction. But the pace of establishing this health and wellness center remains an issue. The second important aspect of strengthening health system is having a surge capacity for managing increased number of patients. And this could be made by various ways, and most commonly done is network of public hospitals with planned access of beds, staff, and equipment. There are several other ways also, including placing private hospitals under public authority, and this is especially possible under the Disaster Management Act, and some of the states, in fact, adopted this approach. And third option for managing the surge capacity could be meeting this additional capacity through insurance. In fact, at the end of second wave, several states prepared plans for the surge capacity, although these plans were never executed because the hospitalization due to COVID-19, due to third wave, was very low. But what is also required is that every state need to have such plans for meeting the surge capacity, and also a mechanism to institutionalize these plans. Strengthening health system also includes strengthening our disease surveillance system, and I'll talk about it later. But one important thing that India needs to concentrate is strengthening our mortality surveillance. And as I showed earlier, COVID deaths in India were highly undercounted, underreported, and that is one area we need to strengthen. The lab systems that have been established now for COVID-19 diagnosis need to be sustained, and we need to find out ways for sustaining this network. And for doing all these things, we need human resource capacity. And for all these activities, we need funding and financing mechanism. There has to be increased funding to health. WHO also recommends after-action reviews, especially when large outbreaks have happened. I remember such review happening in Kerala when there was a Nipah outbreak. And I think this is a time now that every state conducts after-action review, just to find out as to what went right and what did not go right at the time of COVID pandemic, and identify areas for strengthening. The second important lesson which I think can be learned during, based on COVID pandemic is the role of private sector in the pandemic. And here I want to give an example of the famous Mumbai model for COVID management. I'm sure many of you would have heard about this model. In fact, at the beginning of pandemic, Mumbai had one war room which was coordinating the COVID response. But when the new commissioner took over sometime in April of 2020, what the first decision he took was he dismantled that central war room and he established 24 war rooms. There are 24 wards in Mumbai. And one war room was made for each ward. And each war room had 10 dashboards, 10 doctors, 10 medical teams, 10 ambulances, 10 telephone operators, and 10 teachers. Another thing that they did was the commissioner called a meeting of all big private hospitals in the city. And they told that he basically requested these hospitals to hand over their beds, including ICU beds, to the BMC, and they will be charging a fixed rate for managing these patients. Several jumbo facilities were established in the city. So what happened in Mumbai, like all the COVID testing reports, they were sent first to the corporation. The patient did not receive reports directly from the labs, but they received, the lab sent the report to BMC. BMC then sorted the reports and sent it to the respective war rooms. And war rooms contacted the patient, and depending on the condition of the patient, they directed the patient to a particular hospital where there was a vacancy. If required, ambulances were provided for transport of a patient. And with this model, Mumbai could manage more than 15,000 patients a day during first as well as second wave. So this is one important lesson that could be learned, that private sector, the role of private sector during the pandemics or emergencies. The third important lesson, what I feel can be learned, is need for having strong data system and also need for sharing this data for effectively making the use of this data. In fact, during COVID-19, since initial stages, ICMR established a testing database for all individuals who underwent COVID-19 testing. And that was a separate data portal that ICMR still maintains. It had some information about demographics as well as clinical detail. Later on, Ministry of Health developed another portal. They did not use the existing portal, IHIP portal, but use a separate portal called S3 portal for collecting data about hospitalization as well as outcome of these patients. And it took quite some time to merge these two databases. Linkages was an issue. Also, the timeliness as well as completeness of these two databases, again, was an issue. When COVID-19 vaccination started, we had CoWIN portal, which was collecting data about the vaccination of the patients, of the individuals. And again, this vaccination, the CoWIN portal was again not linked with the outcome, patient outcome data. So, on the contrary, if you just see an example of UK's vaccine surveillance, the UK Health Security Agency, the surveillance strategy had four important aims, primarily to monitor the coverage, identify any adverse events because of vaccination, and very importantly, estimate the vaccine effectiveness against wide spectrum of disease outcomes, against variants, as well as duration after vaccination, and identify risk factors and outcomes of vaccine failure. And what UK did was, this surveillance strategy was made through their national immunization management system, very similar to what we had CoWIN portal. They linked this immunization data with the COVID-19 surveillance data. And if required, they also conducted cohort studies or test negative case control studies. And because of this linkage, UK was able to generate on a weekly basis certain outputs, like the upper three graphs shows the vaccine coverage of 1 dose, 2 doses, and 3 doses by age group. They also generated periodically the data about vaccine effectiveness against infection, against hospitalization, against mortality, and also against variants. Also vaccine effectiveness after the duration after vaccination. We were not able to generate this data primarily because the two databases about vaccination as well as outcome were not linked. The next important lesson I think can be learned is need and capacity to have evidence-based decision making. In fact, Dr. Ramankutti talked about evidence-based decision making in his talk. And during COVID-19, as I mentioned, several guidelines were issued by the state as well as central government for clinical management of patients, as well as for policy level, policy health decisions such as quarantine, such as isolation, and so on. Most of these guidelines were based on the evidence that was available at that point in time. And most of the time, this evidence was not the best evidence, was not coming from RCTs or were not even coming from observational studies. And therefore, many of the decisions, the evidence was conflicting. And one example could be a treatment protocol, the drugs used in treatment protocol. Another example could be the decision of that interval between primary dose and booster or precautionary doses. Had we had a better data to support this decision, our decision making, our confidence in our decision making would have been much better. Another example I want to give is about non-pharmaceutical intervention. Several states and several cities implemented night curfews or weekend lockdowns. Whether they are really effective in reducing transmission, we really don't know. During the first wave, we had a national lockdown when we had only 500 cases. But probably based on the experience of first wave, it was decided that during second wave, the local data should be used when the decision of the state or district level lockdown is taken. And the criteria that were decided for implementing such measures were test positivity as well as bed occupancy. The next important lesson which I feel is the need for policy relevant research. And during COVID-19, ICMR, several medical colleges, as well as research institute conducted several research, including participation in the solidarity trial, RCTs, studies on COVID vaccine, both preclinical as well as vaccine trials, as well as national level sero surveys and vaccine effectiveness study. Overall, I would say that ICMR, India has done reasonably well in terms of research. But there are several areas where we would have been much better if we had a better evidence. And just to again give example from the area of vaccination, we really did not have a very large cohorts of vaccinated individuals or infected individuals, which could inform us about interval, what is the optimal interval between booster doses, about reinfections, about durability of immune response, about long COVID and so on. Again, we had some studies from India about vaccine effectiveness, but these were planned studies at one point in time, and we really didn't have much data when we required about type of the vaccine effectiveness against type of each vaccine, about duration of vaccination, and vaccine effectiveness by variants. The next lesson which I feel can be learned is the importance of public-private partnership. And here I want to give an example of the co-vaccine journey. Because ICMR partnered with Bharat Biotech, it was possible for ICMR as well as Bharat Biotech to develop vaccine within a period of 6 or 7 months. And as you can see in this timeline, It was in April 2020, the ICMR and Bharat Biotech signed an MOU. And then in May, ICMR NIV transferred the virus strain to Bharat Biotech. And by November, the results of phase 2 trial came out and found that vaccine is safe and efficacious and immunogenic. Based on that, the phase 3 clinical trials were started. And in January, we know that Government of India or the DCGI approved or gave emergency use authorization for vaccination. So this all was possible because of partnership with an industry. So industry partnership is again very important during such pandemics. And the last lesson I think is need for community engagement. And this is a cornerstone during outbreaks, especially if you want to have a buy-in from the people as well as for sustainability of interventions. And most of the interventions that were proposed during COVID-19 had a top-down approach, but the importance of bottom-up approach cannot be really ignored. And there, of course, have been some examples of engaging community for COVID-19 response, including the use of community-based volunteers in contact tracing, as well as in purchasing rations for families under quarantine and so on. Several states had community kitchens for providing food for migrants or quarantine and isolation centers. But again, I think this was one area which was not really exploited during the pandemic. So just to summarize, I think for future pandemics, these are the 7 important lessons which I feel could be learned from COVID experience. We need stronger and resilient health systems. The private sectors play an important role during managing surge of patients. We need a stronger data system, and also the data need to be shared, periodically analyzed. We need capacity as well as a culture to adapt this evidence-based decision making and have a policy-relevant research. And finally, the importance of community engagement during the response. Thank you very much.
Thank you, sir, for your vivid presentation. And now we understood the importance of the partnership between the private as well as the government sector for controlling of these epidemics, as well as what is the importance of participation of the community members. Thank you, sir, once again.
Any questions from the audience?
Thank you, sir, for the very good presentation. And as a person in the other side, clinician, primarily we were seeing patients and managing. The most frustrating thing, everything was frustrating and disturbing, but the most frustrating thing was the data capturing. Every day, data, new forms will come, new things will come, you upload in this sort of format. And this was most difficult even for the field staff. And they were working continuously during the daytime, and night they were having sleepless, especially the grassroots workers. They were entering data, and next day morning the format will change. And different type of platforms, as you have rightly pointed out. And most unfortunate that those who are sitting at the other side, I would like to know what is happening in my ICU. I would like to know how many patients are increasing, but I will never get it, though we are continuously entering the data. So I think from ICMR side, and as National Institute of Epidemiology, if a similar outbreak or pandemic comes again, how we can be empowered in a similar situation, how to make it more friendly. Because each institution, for medical colleges, in our center, we were not having that e-health platform, but most of the institutions has their own platform. So they are doing their own data entry. But being a pandemic, we have to do it. So I think that was the most challenging thing. Everything was challenging, but this was more difficult for us, and we were never getting the report. That is natural because we don't have in that test labs. But even after getting the test lab, I thought, what we can do for that part, if something similar happens in our place as a national perspective. Thank you, sir.
I mean, I do agree with you fully that there were issues with respect to different formats, and so at least if I talk about lab surveillance data, that is at least complete and that was timely, although there were some delays. But patient outcome data was coming very late. Even what proportion of patients were hospitalized? What is the severity of patients? Even at medical, I mean, at the state level, this data was not available. So what I think need to be done is, like in IDSP has this IHIP portal, which most of the states are using now. I mean, if such portal could have been used, and ensure that this data is analyzed because you don't need to be analyzed at a national level, everything. Because the data is important at a state level or a local level. If such analysis is done at a state level or district level, that will be much more efficient. Mortality, for example, because every state announced that, okay, so many deaths were there. But how many of these people who died had received vaccine? This data was never there in the database. Because there are no linkages between the COVID database as well as the hospitalization database. So because of that, we were not able to generate any data in the real-time manner about vaccine effectiveness against mortality, against hospitalization. So I think there is great importance in linking the different databases, having timely data, and we need not collect data on big data, like 2 or 3 or 4 page this one, but at least the severity, whether it was mild, moderate, severe, even that is classified, that is much more meaningful. Because after the second wave, everybody was suspecting that third wave is going to be very severe among children. And when Omicron came, we are relying on the reports from South Africa, but we had, for quite some time, we didn't have data from India that, okay, how much is the hospitalization because of COVID.
So that was a very nice and vivid presentation. Thank you very much for the presentation. So in public health, we recommend 3 types of surveillance. Symptomatic surveillance, to collect information depending on the symptoms, and the patients having similar symptoms in the same locality will be counted. And then the presumptive surveillance for when the medical officer confirms the clinical disease clinically, it will be counted as presumptive surveillance numbers. And then finally the lab surveillance, which are actually the confirmed cases. But in COVID scenario, we didn't see about the symptomatic surveillance and presumptive surveillance in the data picture. There were only lab surveillance, only confirmed cases. Was there any specific reason for that? That's one question. Second one is quality of data. So that is very important. Without a quality of data, it is difficult to make analysis properly and to come out with interventions to control the disease, either in the clinics or in the field. But in the case of IDSP surveillance system, we suffered a lot, and we were because of the lack of coordination or cooperation from the clinics. As the madam mentioned earlier, there were a lot of incorporation from the clinical wards to give the proper data when there are 1,000 fever cases, they will report only 50 or 100, etc., etc. So that also might have affected the COVID data also. What about your comments?
Your first question about different levels of case definitions during COVID. I mean, all over the world, the lab confirmed cases were what was counted. Only during the third wave and after that, people stopped testing basically. And then when anybody had symptom of suggestion of COVID, they thought they had COVID. They depending on their condition, they decided whether to get hospitalized or have home isolation. One probable reason for that could be because there are a lot of asymptomatic individuals who are positive and who transmit the virus, and that's why that could be the strategy recommended for testing. With respect to data, I fully agree. There were no linkages between the lab data, between the hospital data as well as vaccination data. And I mean, one solution is at least have some information, a basic demographic information, and some information about the outcome, whether the person was having a mild, moderate, or severe disease, and what was the outcome, whether he survived or died. I mean, this information could have helped us in properly documenting what or making the analysis. So I agree. During COVID, there were several issues with respect to data, and that is what I think is the main lesson that could be learned during future outbreaks. Is have the database simple. Don't make it very complicated. Whether what was a lab investigations or reports of lab investigations, and whether person required oxygen and how much was oxygen saturation and so on. But a simple case classification like whether it was a mild case, moderate case, severe case, and whether a person died could have helped us in better documenting the scenario, the epidemiological picture of the disease.
Thank you, sir. We are running short of time. And now it's time for tea break. I request all the delegates to reassemble back at 11:55 itself. Thank you.
ചെയർ ഇൻവൈറ്റ് ചെയ്തിട്ട് വേണം പറയാം.
Dr. Jain B., Dean Faculty of Ayurveda, Siddha Unani, and Dr. Krishnan B., Dean Faculty of Homeopathy, KUHS, kindly requested to occupy the seats.
Please bear with us. In absentia, we are starting. Jain. തുടങ്ങ്, സമയമില്ല നമുക്ക്. കൃഷ്ണനില്ലേ?
Over to you, Dr. Jain and Dr. Krishnan B.
Good morning, all dignitaries on the dais and off the dais. Professor Dr. Suthi Kumar, Professor in charge of School of Fundamental Research in Ayurveda, Kerala University of Health Sciences, is about to present a topic titled Translating Research Evidence to Policy and Practice in Ayurveda, the case of Kerala for handling pandemic. Suthi sir has been working in the field of Ayurveda for the last 4 decades, and he is the right person to present this paper here. I invite him for the presentation.
Good afternoon. Respected Dr. Jain and Dr. Krishnan. First of all, I thank Dr. Rajmohan sir for giving me an opportunity to address you people. Translating research evidence to policy and practice in Ayurveda. I will explain this through some research, COVID research recently conducted. So the problems and difficulty of translating into practice, you can understand, I think. So, translating research evidence to policymakers and practice is a difficult thing. As said by Dr. Ramangood sir, policymakers living in another set of agenda, and the researchers do their research based on their interest. Because particularly in Ayurveda, there are some research institutes conducting research and universities are conducting research. They are conducting research based on their own ideas or interested areas they will find out and research. What is the ultimate aim of the researcher means to publish a paper in the index peer review journals. These researchers may read some more articles, but naturally policymakers rarely read these articles. So they are not aware about what is the research going on it. And of course the policymakers is definitely they are having some agenda to making the policy, because that is in a democratic country, always the politics will be there for making the policies. So there is no effective communication between the researchers and the policymakers before or after conducting the research itself. So there should be an effective platform and I think the university is the most effective bridge in between these policymakers, because university can influence the policymakers and the researchers. Of course, it's a part of the or institute, even the research institutes, they can take care of it. What should be the next 25 or 50 years research should be there. And particularly in Ayurveda, I am not explaining the slides because it's lack of time I'm running it. This is an age-old system of, and there was not enough research conducted on, and particularly of the only this system is having this problem, and it is a highly personalized research area, and it is the Kerala. It's at least the need of research and documentation developing standard protocol of emerging and re-emerging disease, of course, and particularly in the particular scenario of the COVID only. This any pandemic or epidemic, we have to, because our system is a highly personalized medical system. So one person to person, it can change. And translating this information gathered through research has to make simple, easier to understand, and should communicate to the practitioners of Ayurveda. That means researchers do research and publish in journals. They may not be easily understandable for the policymakers or even the practitioners. Even the practitioners are also rarely read this up-to-date journals. And of course, another problem is their journals to get a research journals, gathering the research journals itself very difficult for a practitioner. So particular area they may be focusing, and particular area journals they may be reading. So university can bridge this gap between the researchers and including the institutes and policymakers, practitioners and academy. Academy could do more communication with the policymakers and practitioners. That means the university have to do the more communication between the policymakers and researchers. And of course, this dissemination, before dissemination, the credibility has to be assessed. That also is part of the university. Every research outing, because even based on single research paper, nobody can predict this may be beneficial or not, or particularly in clinical research field. In Ayurveda, of course, there is a clinical research field, and we have in need of tool development and all. So that's particularly to our system only. There's inadequate link between policymakers, as I said earlier, and even Ramakrishna sir said same thing only. Policymakers don't know what the research area is. Researchers are as an allied community. They are doing research, and they think they are well learned everything and all. Same thing policymakers will think. They are knowing all the things. Why should we read all these research fellows? That is there. That has to be faced. Inadequate policy-based researchers, because why there is no priority area. We are not knowing, the researcher is not knowing the priority areas of the policymakers. So that gap also has to be filled. That gap also can be filled by the universities only, because translation research, that's why the university is trying to do it, the translating part. Because Ayurveda treatment is based on many variables, and even person to person it can change, the drug can be changed, or even multiple pathogenic conditions, a same drug can be effective, or a polyherbal formula can be. These problems I will explain through the CTRI registered trials. See this, there are single drug-based trials are in, totally 145 trials registered during this April 2022, June 21. So that is single drug trials are, even so many single drug studies are there. That means more than 21 single drugs studies are there. Polyherbal drugs are a combination of 29 are then multi-drug formula. Even this can be same seen in the published in PubMed also. The 40 relevant, of course, 243 articles relating to Ayurveda and research is there, but 40 are 11, and that also are only 7 clinical trials that are also based on single drugs or polyherbal formulation, different formulations. This is one study that is initiated by CCRIS. So this part is a translation of this research into practice is well done in here. But what is the dilution of the research methodology is happened. Of course, there is self-explanatory, the slides is explanatory, the research dilution is there, and the evidence-based grade, it is very low. That means it is 87 centers and in of the 27 states and 5 union territories, this study was going on. And because of so many compromise occurs that we can visualize in the slide itself. And because some RT-PCR only 32% included person only done, some vaccinated and some non-vaccinated are like that. But results say 98% gave negative RT-PCR after 21 days. And analyzing of 50,000 people, it's like that. And here the Kerala government, that policy maker, researcher, and practitioners are all are part of this one. Only because it's a community trial. So that also the grading also will be just like a case report only, this grading comes. So, and based on the several program, Sasthyam, Sukhayishyam, Amridam, that is a government, that is a policy making, they decided into it. And it is well conducted, this one. But that also, this grading level research is grading. But translation level, it is good because all over Kerala, this work came to know, and all the districts are still completing it. See, this is a Kozhikode district that has till dates 19,000 they are ended. Then there's another study was that in Kannur. That is one of the collaborative, Government Medical College and Government Ayurveda College collaborated as a center for this one. And that is another part, that collaboration was there. So translation part was very effective in this one because almost all the students or those who are the doctors came to know about these research, what is going on and all that. But again, see the research evidence is, grading is less. And of course, this is our center that among the practitioners, we had a cross-sectional study. Because what are the day? Again, we came to know that many are using many drugs for attaining the goal. Of course, the goal attained within for 21 days. But that as a sense of research, it is very, very qualitatively very poor. And then single drugs and formulations studied most are this only for this 29, this Gudiji, Tinospora codifolia are done because of the adaptogenic and anti-inflammatory, antipyretic, antioxidant, immunomodulatory, antiviral activity. It may be done. Another and single formulations is I-64 and Chavanaprasa is well done. And to conclude this, for better translation of research into practice, a guideline for management based on the research findings has to be prepared by the university and communicated periodically with the policymaker, academy, and practitioners. And the policymaker should inform the areas of research needed to the university. So the university can easily translate their things to the research evidence to almost all the policymaker and research. University is a center point, the policymaker and researcher, and university can communicate to the academy and practitioners as well. So, thank you.
Thank you, sir.
Good afternoon to all. I am extremely happy to see the presentation of Dr. Sudhikumar sir on behalf of Ayush stream, and I see the excellent work of this combination as well as single drugs in treating as well as preventing the COVID among Kerala scenario and in India. So this is a hard work as well as efforts that found good results. I congratulate all, and I thank School of Public Health for inviting me for this session. Thanks all.
Thank you, Sudhikumar sir, Dr. Jain, and Dr. Krishnan P. Now we can move on to the next session, knowledge synthesis and interpretation. We have with us Professor Dr. Srikumaran Nair, Professor and Head, Department of Biostatistics, JIPMER, Pondicherry. He will talk on the session, Craft of Evidence Synthesis from a Quantitative Data Analysis Perspective, Handling Bias, Confounders, and Power Consideration. I also request Professor Dr. Shankar Sharma, Professor, Achal Center for Health Science Studies, SCTIMS Thiruvananthapuram, to chair the session. Over to you, sir.
So good morning, esteemed participants. This session, Dr. Srikumar Nair is going to present various principles behind synthesizing evidences that are generated. As we know, researchers from across the globe in various places, similar researches are done and evidences are made at individual level. But whenever we have contradictory evidences, it will be very useful to look at how we can make sense of all these individual evidences and how to synthesize them. So, over to Dr. Srikumar.
Thank you very much, Professor Sharma sir, and definitely Professor Rajmohan inviting me to be here. So I'll be next. I think still I have, even though we are running out of time, we have a half an hour. I hope so. I will try to finish before that. So it's the title given is Craft of Evidence Synthesis with Quantitative Data. Then I had a discussion with the next speaker, my good friend Dr. Pratap, what to talk, because both of us will be covering more or less overlapping and complementary sessions. So the decision is I talk about meta-analysis, and later Dr. Pratap will be talking more about its overall systematic review and reviews. Okay, so that is a way understanding we have. So there will be a little bit of overlapping between us, but otherwise we try our best to be complementary in it. Okay. So basically what I would like to cover upon this, it's yes, I'm for last many years been a statistician, so sorry, little bit of statistics I will touch upon. Okay, so if you are thinking that without any statistics I will be talking, no, it's a little bit of statistics. So sorry, apologies for that. Okay, so what I start with a systematic review meta-analysis. Some basics I will talk. It's then I move to statistics. It's meta-analysis, model building strategies. A little bit I talk. Heterogeneity. That is another issue. It's especially Dr. Rajmohan asked me to touch upon that. Then something called a subgroup analysis will touch upon. Then publication bias. In fact, in the systematic review, how do we look at the publication bias? And that is so each session is equivalent to maybe 1 hour session. So I will try to cut down into 5 minutes, and you can imagine how it moves. Okay. Of course, it's my acknowledgement. It's yes, a Cochrane collaboration, which is an organization over a period of time trained me in getting these materials in place, talks in place, and knowledge in place. So it's my acknowledgement to Cochrane collaboration and Cochrane community. Okay, when we look at the creating research evidence, there is nothing to replace primary research. If somebody think that it's primary research is not required, no. Primary research has to be there, it will continue to be there, that's it. Then, based on primary research, data you generate, and that data later people use secondary data analysis, they do, and they answer many important questions. For example, that's what you find in NHS data. Yes, it's a year after year people use to answer different questions not posed by NHS themselves, okay. Then as narrative review, I think it's all of you sitting here, you are familiar with that one. The journals, usually editorial members, it's generally write narrative reviews that. Okay. Then comes something called a systematic review and meta-analysis. That is the one we are going to talk here.
Look at it, this systematic review, what it is. I have one slide, and the remaining, Dr. Pradap will be talking more about it. Okay. It is again like any primary research, answering a focused research question. So there is a research question there, and very important in systematic review. But that is answered not based on the data. Again, you go around and collect it. It is based on the data which is available in the literature. And when we use the name data available in the literature, means results available in quantitative terms or otherwise in the literature. Okay? But the most important strategy is there we use scientific strategies to limit bias. We don't want to tell we eliminate bias, because it's many times we thought of eliminating many things, including many various communicable diseases. You realize that it come back again. Okay, so we don't want to tell that we eliminate, but limit as much as possible, control as much as possible the bias, in terms of systematically getting it into place, critically appraising it into place, and then finally synthesizing it. Okay. So the first few parts, I leave to Dr. Pratap, and synthesis, that is the one. It's in fact what I mean is meta-analysis. That is the one I am going to talk it. These are the steps in systematic review. I thought it's just to put it up it, and I am touching upon that step 6, analyzing. For example, if you look at this, it's a primary research. What is the structure you have to have? Exactly same structure you have to have a systematic review. Sometimes we ignore these things and we claim that we have done a systematic review. You have to have a clear structure, you have to have a protocol, and protocol has to be published. Cochrane insists on it, and many agencies now insist on it. Okay. So anyway, I'm not going to the details of all those things, but I'm touching about the first word in the step 6, that is analyzing it. Okay. Once you have done all other things up to 6, up to 5, and then you have data, and then how you can pool. When I use the word data, results from different studies. It could be odds ratios, confidence interval, relative risk, or hazard ratio, or prevalence, or incidence coming from different studies. How we can pool all those prevalences together and get one prevalence. How we can combine all those things. That is what. Okay, and that's the place I am, the meta-analysis. The basic definition of meta-analysis is, it is an analysis of analyzed results. That's the way simple you can put it. It's you are analyzed the results, okay, combining from them. And that is what Glass coined that term in 76. But if you look at the literature, if your curiosity, you go back, R.A. Fisher in 1905 and Carl Pearson, they also have done pooling of results. Okay, that is what design of experiments or analysis of variance they have done. But they haven't coined the term meta-analysis, as well as more detailed way they haven't structured it. Okay. Now, with that, I thought I take up an example, and based on the example, I talk. This is from Cochrane Collaboration Acute Respiratory Infection Group. I took up this. But please remember, I am using 5 studies. They have had some 20 studies in this. So what I am telling is, my apology, don't try to interpret the results immediately, because about 20 studies were there. For simplicity, I have taken only 5 studies. Okay, that is it. Now look at it. The question here is, erythromycin is better than amoxicillin or not in terms of treating lower respiratory tract infection. Okay? And they looked at it, their conditions were there, only clinical trials they include. And finally, they found, suppose, 5 clinical trials. In fact, they found it's 15 or 20, but I have a demonstration purpose, I took only 5. Study 1, clinical trial 1, it has got an odds ratio. I think it's all of you sitting here, you know how to interpret odds ratio. Yes, it is 0.64. It's with a confidence interval 0.14 to 2.65. So by confidence interval, you start interpreting. That means both drugs are doing equally good or equally bad. You cannot tell one is better than the other. The reason is it's a odds ratio, that a confidence interval, yes, one is within that interval. That is a very simple statistical explanation. You look at the study 2, yes, it tell, even though there is an odds ratio 16.6, very high, but it tells it's probably the other control group is doing better than the intervention group. That is, sometimes surprises happens, okay? Your control group is better than intervention group. Look at the studies 3, where 0.46 is the odds ratio and 0.31 to 0.71 is the confidence interval. Pretty well it says, okay, it is an important study and it tells azithromycin is doing better than amoxicillin, okay? Like that, it's, you can keep on in the. Now the question is, yes, you are getting confusing results. The problem is you read more and more. If you read only one article, you are very clear. But when you read more and more, you get, that is what it's, earlier people were talking about reading more and more. When you read more and more, you get more and more confused, okay? Now, you have a confused odds ratio point moving from 0.64 to 16.4. That's so many things. Can we combine these together, pull together, and get one odds ratio for interpretation? Not only that, can you pull all these confidence interval and can get one together? Yes. It is possible, and that is what meta-analysis, I'll be talking a little more about that. Okay, 0.66 and 0.46 to 0.96. So evidence is, if suppose you would have had only these 5 studies, evidence is very clear, azithromycin is doing better than amoxicillin, and probably it can go to the policy recommendation. Okay, now, how do you get this 0.66 and 0.46 to 0.96, and what are the assumptions it's under that? Those are the things we are going to talk another 5 to 10 minutes, okay? How we arrive this, and that is what it is called meta-analysis, okay? The way of representing this, it's usually people call it as the forest plot. It's exactly earlier table, but it's more in a graphical way it is put. It's okay, so that's all. The center point, it's that particular effect measure, point effect measure, and the width, what you horizontal line you are finding, it is the width of the confidence interval. And it's, when you look at the more details about this graph, we come back again and again, and we will see that, okay? Now, there is another confusion. It's people think it's many times the used word is meta-analysis and abused word is again meta-analysis. It's the thing you find even journals, you find a meta-analysis being published. But please remember, a systematic review, it's a first and foremost important one. Okay, you have to have a systematic review in place if you are looking for evidence-based policy. And when you systematic review, generate quantitative data, effect measures, probably you can do a meta-analysis. If it won't generate quantitative effect measures, still that systematic review is valid, and I think it's Pratap will touch upon that also. But that light blue one, it is very dangerous zone. A meta-analysis without systematic review, it is so dangerous, it gives very biased results, and if you go ahead by hearing the name of meta-analysis and take that without a systematic review meta-analysis done for your policy, probably you are doing something wrong. If without any knowledge you formulate policy, that would be better, okay? Now, so these are the basics of systematic review and meta-analysis. Now I move to, don't worry about this formula and things up there, okay? Sometimes that is the problem. Statistician talk, for our survival, we put some formula in place. Don't worry about it. But there is the thing you have to, if anybody attempt to read a systematic review even, or take a systematic review research in your policy, you have to worry about this particular slide. In the sense, it asks a question, even if you use a package, it asks a question, what is the model used for meta-analysis? Is it a fixed effect model or it is a random effect model? This is one of the points you have to, even if you use a package, you have to click there. It's a fixed effect or random effect. And how do you do that? And there is a major assumption going with it. We have 5 studies here. One study coming, it's RCT coming from, could be UK, one is from India, one is from Australia, like that, 5 different places. Or even it's all 5 from India, but from different states and different population contexts. It is coming. Now, can we make an assumption that apart from randomness, all these studies looking for one and one true effect. It is a important fundamental assumption I am putting to you. Can we make an assumption that apart from the random differences from different regions or different studies talking about the same truth, if you tell yes, then you can go for a fixed effect model. Otherwise, you are not permitted to touch a fixed effect model. Okay? Once you tell that assumption, it's okay, I can go ahead with, then there is a model. We assume that, don't worry about it. So what I assumed that this green one, all are having the same truth. That means study 1, actually you measured is this, but truth is this. Study 2, actually you measured odds ratio is this, truth is this. Study 3, actual you measured is this, but truth is this one. That is, central line is the truth, but each study measured a little bit deviated, and that deviation you consider as randomly it happened, nothing more about it. Okay? If you assume that, then I can assume this model and I can do some computation, and that is what fixed effect model and sometimes inverse variance, it's a weighted average, you call it as. Okay? So that is a study, this odds ratio. So now, another 2 slides, little bit, I thought since it's Dr. Rajmohan said it's a workshop, I thought some work also I put it in this talk. Okay? In the sense, if you assumption you made it's a fixed effect model. Okay? If so, how do you calculate weighted average and how to calculate that odds ratio and confidence level? Look at it. I went to the raw data. It's something, all 5 studies. So take the first study. With the first study, I may take 1 or 2 minutes to demonstrate something, and then we move forward. Take the first study, 48, 4 events happened, so 4 out of 48 versus 7 out of 56. And based on this, that is the results of one study. Please understand, one RCT, it may take 3 years to complete, but the results for us is 4 out of 48 versus 7 out of 56. That's all we are taking it. And what do you do? Okay, so that based on that first study, I made a 2x2 table, and you know, as an epidemiologist, clinical epidemiologist sitting here, how to calculate variance of that particular study. You got the variance, and once you have the variance, weight of that study is inverse variance. This weight, later forest plot, I will show you how it appears. So the weight, you got it as 2.27. What I am telling is, each study, according to the data it brings, you can give a particular weight to that study, even a quantitative weight you can provide to that study. And that is the way you got this weight. You look at it the weight, 2.27, 1.72, 20, 2.7, 2.56, all weights calculated individually for that. Okay? Now, for more understanding purpose, you can convert that into percentage, because total weight is 29.25. 2.27 divided by 29.25 into 100, you get percentage. And look at there. Fascinatingly, the third study is eating much more. 68% of the weight is gone to third study, and evidence probably should fluctuate towards the third study. That's what it's happening, just to look at that. So, but what I'm telling is, this is the process behind the scene it happens to get the effect measures in place and summary effect measures in place. And then based on that, there are ways it's to pull these results, and it's logarithmic terms you have taken, and in terms of odds ratios you can go for it. All those things you can do it, and then finally you get 0.67 as the effect measure and confidence level of 0.46 to 0.96. Okay, so what I wanted to tell is, behind the scene, lot of things, a lot of assumptions happens, and that is how it look at it. Now I came back to the same slide. The reason is the third slide, the third point. If you look at it, why it is little bit fatter? The reason, because it got 68% weight. That is why it is fat. Okay? That study is attracting or contributing maximum to this evidence. It's okay. That's it. So that is the way it is pulled, and final diamond. Usually we call it as diamond. That last one, it says 0.46 to 96. It's a believable level of evidence you get, provided your assumption it's a fixed effect model. Okay? With that, I change to the next one. Look at it. Now, I bring something called a random effect model. Earlier, I used the luxury of assumption that all five studies have same truth. And probably one of you can ask me, corner me, it's why, how you can make such an assumption? One study from UK population, another study come from Australian population, another from northern part of India, another from southern part of India. How you tell? It can, each one, why don't you assume that each one has got its own truth? Now the question is, can we make such an assumption, then move forward? That is what basically random effect model allow you to do it. Okay? Each study has its own truth. Still, with that assumption, can we get a summary effect again? Pool one and pooled confidence interval, and we can get it. And that is what down, if you look at that model, it is not two terms there, three terms are there. What we are telling is between study variation and within this, there are two components we built up in the model, and that is how the calculation is done. And once you make your assumption change that you are making, please take ownership of that. Don't think statistician is making that assumption or someone else is making the assumption. Whoever is taking ownership of the systematic review, that's the person making that assumption. But once you change that assumption, the way you calculate weight changes, everything changes, and the way you get weight and its standard error, confidence level, all those things get changed. Okay? And then you get something different for the same data. Please understand. You changed the assumption, and now look at the evidence where it has gone. The fat one has come down. The fat one has gone for some exercise probably. Okay, third study. No, it's a weight, you look at it, 24 only. 68 was the weight, but it has moved to 24. The weight has come down when you changed the assumption. And not only that, evidence is not very conclusive towards its erythromycin. That is what it's happened. So please remember, when you assume the model, you have to be very, very careful. Not only careful, debate over it, it is all right or not. Okay? So look at it. The same data, two methods assumption and how things have changed. Okay? That is why you have to have some insight into the process to really read this evidence. Otherwise, sometimes misleading it could be. Okay? So that's all the meta-analysis, that the computation part, because two other things I have to finish. Then another thing I was asked to little touch upon is heterogeneity. Okay? People talk about heterogeneity, but when we in systematically we talk heterogeneity, there are three heterogeneities. One is clinical, another is methodological, another is statistical. Clinical means, yes, there could be a dose difference. It's in terms of one trial was 250 milligram, another trial was 350 milligram, another trial was 500 milligram. Okay, population wise, it's one trial was under 5 children, it's happened, another trial was under 15, it happened. So there could be a lot of clinical heterogeneity in that trial, these trials, and it has to be addressed outside. In the sense, if you think that can influence the outcome, probably suggested is subgroup analysis. Then second is methodological heterogeneity. One is the symbol RCT, another is cluster RCT. Can we combine both together? There is a question. So there are methodological issues involved, and if you think that that can some way influence the outcome, please separately analyze, and there are methods to look at it. And once you look at clinical heterogeneity, once you look at methodological heterogeneity, then what is left out? All this taken care of, still your data, there is some heterogeneity, it is there. That is called the statistical heterogeneity, and we have mechanism to measure that, okay? So, but please remember, clinical and methodological, you have to get rid of before coming to the statistical heterogeneity. And statistical heterogeneity, there are measures. Q statistics is the one, I-square statistics or t-square it's used, and even in a chi-square test, it's been applied for testing heterogeneity, significant it is there. There is a test of significance to test significant heterogeneity is there, as well as there is a magnitude measurement I-square. So there are two things. One gives how much is the heterogeneity, another tell that heterogeneity is significant or not. So these things are available, and that is all done. Again, I came back to the same slide. Look at it, that this corner, because I talked about all these points. Now you look at it here, test for heterogeneity. That is what? Okay, test of heterogeneity, and it's this is statistical heterogeneity. Okay, and found to be significant. I-square is 82%, and then probably it suggests for a random effect model. Okay, that's the time it give a clue. Yes, it is better to go for a random effect model because the model accommodate all these variation, capture all these variation, and fixed effect model. Probably it is not right for this situation. Okay, so that is what test of heterogeneity. Now, I know that 2 minutes, I am rushing from one topic to another, okay, but that's okay. I consider it as a little bit of sensitization. Now that is my last point, it came something called, okay, you have done everything, and you are giving it to the policy maker. As did you capture everything? That means your search was complete, captured everything or not. Okay, quite number of years we debated on this issue. Okay, and now we have some level of clarity. I'm not telling 100% clarity that during the process of systematic review, important thing or something unimportant we thought we missed or not to look at it. That is what it is called a publication bias. It's and usually the term is funnel plot. It is applied in that. Okay, that is nothing. It's you have it may be looking at very complicated, but it is very simple. Effective measures and it is uncertainty. Standard error, you put it effective measures in the x-axis and standard error in the y-axis. These are all odds ratios x-axis. This is the standard error y-axis. You plot in xy plane. It's the points. All points you put it. And our assumption is there is very reason for having that assumption. If all are captured, it should come as a inverted funnel shape. Okay, it should come as a inverted funnel shape. This side and this side, as a inverted funnel, it should come. Now look at this graph. What is happening? It is not so fortunate to have a inverted funnel. There are some vacuum here. You are finding this vacuum here. Okay. This clearly gives a suspicion that, yes, something is missing. During the process of our systematic review, probably we missed many studies. And look at what are those studies. It is small-sized studies it could be. It won't get published. It won't, so there are a lot of ways. It is not, I don't want to publish it, journal won't accept it, or reviewer won't permit to do it. So many reasons, but however, that vacuum is there, and that has to be looked at it before the finalizing everything. Okay, so and there is again a test of significance. Eagers test, it is called, to test the funnel. It's the significance of that missing one. Okay, so this give an idea about. It won't tell confirmatively, yes, there are many missing. It give a suspicion. Yes, there is a possibility of missing. There is a probability of missing. Okay, and that is this all I talked. And then meta-analysis. Now there are a lot of areas: network meta-analysis, meta-regression, Bayesian, and multivariate, complex public health interventions, meta-analysis. Those are all areas are there. It's the last 20 years. It's really have been developed a lot. It's okay. And with that, I come to the last slide. Okay, it is. Before you go to meta-analysis, please make sure that search is complete, unbiased, selected using robust inclusion-exclusion criteria. Probably get the same effective measures, and if you don't get it, for example, some studies reported odds ratio, some studies reported relative risk, we can go back and redo the calculation. That's all right, can do it. And then get rid of methodological and the clinical heterogeneity. You cannot get rid of, but you have to do the subgroup and things like that. Okay. Once that all done, then if you have quantitative enough numbers, then do a meta-analysis, go for a meta-analysis. Otherwise, please stop there. Do that systematic review, report that, and write it. We cannot do a meta-analysis because of this reason. The reason is, it's other ways it goes to a GIGO principle, garbage in, garbage out. Okay, you know, unbiased, all you combine together, what you get is more dangerous thing. So please don't do it. And that's a place I stop it. Thank you.
Thank you, Dr. Srikumar Nair, for giving a nice overview of meta-analysis, contextualizing in the general method of systematic review, and explaining the essential jargons that goes with meta-analysis. Thank you, sir.
Thank you.
So we can have the question session after the next session. So we have with us Dr. Pratap Tarian, former professor and head, Department of Psychiatry, CMC Vellore, Adjunct Professor, Clinical Epidemiology Unit, Professor B.V. Moses Center for Evidence-Informed Healthcare and Health Policy, CMC Vellore. And he will enlighten us on the craft of evidence synthesis and overview. And I request Dr. K.S. Shaji, Dean Research, KUHS, to chair the session.
I have great pleasure to introduce Professor Pratap Tarian, who was, as many of you might know, was trained in CMC Vellore and then in the UK Royal College. Trained as a psychiatrist, but went on to train many in evidence-informed healthcare. And it's a pleasure, Pratap, introducing you, and over to you.
Thank you very much. I know I stand between you and lunch, so although I can't shorten it too much, I'll try and make it interesting. I'm very grateful to Professor Rajmohan for inviting me and for Shaji to convince me to come. And it's also a pleasure to have spoken after Professor Srikumar and I, who, along with me, was instrumental in bringing Cochrane to India. It's been a long journey, and what I'd like to give you is an overview of the craft of evidence synthesis. But we first have to contemplate a bit about what do we mean by evidence. And by evidence, we are actually talking about the truth, verifiable facts and data that support a belief or a practice. But the problem is that people differ on what they consider the truth. One man's truth is another man's poison. And there are very wide sources which we look for to find truth. And over the past decade or so, the term alternative news, this is something unheard of until some people made it very, very popular and mainstream. And now we have fake news. So the whole concept of truth has come under a lot of siege. And the big problem for us in medicine is, can the evidence be trusted? And there are a lot of publications, very well written publications, which show you that it can be proved that many claimed research publications give you false results. And the reason for it largely is because there are a lot of vested interests in trying to propagate a particular belief system, either for commercial reasons or for academic reasons. And usually this results in a lot of unnecessary research or inappropriately or poorly designed research, which is reported in such a way that convince you or of a particular point of view. And when you try and use those results in clinical practice, the health outcomes that you get are very suboptimal. So many trials, for example, are designed to deceive you. And as clinicians, unless you know the way in which this trial is designed and reported, you will be deceived by it because we trust whatever is printed. So there's a lot of stuff that we as clinicians need to be aware of before we can actually accept publication results. And there's a lot of undisclosed conflicts of interest and a lot of reasons why people want to even manufacture disease. So for example, when we studied, the cutoff points for hypertension, diabetes, and all are quite different to what they are now. That's because when the drug markets, the population that is drugs are being sold to get saturated, the only way to increase sales is to reduce the definition. So you get a wider population of people who have a particular disease. And it actually doesn't result in any good outcomes, but it results in greater profits. So the other problem is, I do not know whether you believe it, but in this country there is a great pressure from academic institutions in many states to publish. The Medical Council of India is asking all government hospital doctors to have publications, which should be in particular quality of index journals, without giving these same doctors the resources to do good research. So this particular article is very telling. It tells you that from a group of articles which are actually published in high impact journals, you can classify them into 4 quadrants. One quadrant shows journals which actually advance scientific knowledge. One quadrant has practical applications which can be immediately realized. And one quadrant has papers which do both. But the vast majority of papers published today is what you call research waste. It doesn't advance science. It doesn't help anybody except the individual who does the research and publishes it. And in our country, this pressure to publish has resulted in a lot of senior academicians from reputed institutions contributing to research misconduct, which can harm patients, distort the evidence base, misdirect research effort, waste funds, and damage trust from the public in the methods of science. And we also know that we actually need reliable evidence, as was evidenced during the pandemic, when you found single studies, opinion pieces, all getting rushed into policy to make people better with this. So what we need is reliable evidence which can actually improve health outcomes. For that, we need relevant evidence which is focused on a particular question where you've clearly defined the population, the intervention, or the exposure, the comparisons, and outcomes. And then you need to find studies addressing that particular question, and these studies should have used study designs which are appropriate to answer that question, and which actually have reported the methods of how they did it so you can know whether you can trust it. And when you finally say, this is the body of studies I want to look at, you need to make sure that you have got all the studies, and not only the studies which are easily available, because you search PubMed and didn't realize there are a whole lot of other databases where some studies get indexed, and not only PubMed. And we also need to know that in these studies, what were the methods used? Were they appropriate, or could they be giving us biased results? So we have to have a mechanism by which we can assess the risk of bias in each study. And then when you get your final result, your pooled results, you have to ask yourself, are we going to go by a p-value, which will tell you how confident are you that the results difference that you see is not due to chance. That's all it tells you. So p-value of less than 0.05 tells you you're more than 95% sure this difference is not a chance difference. It does not tell you how effective it is. So you've got to go beyond statistical significance and look at clinical importance. And when you look at clinical importance, you need to ask yourself, what is the minimum clinical importance I need from one treatment to the other to say I am going to change my practice? So you can get a minimum difference of 2% in some rating scale or some headache symptom questionnaire, but that 2% difference from a randomized controlled trial where you control everything, when you translate it into the real world where you control nothing, is not going to be 2%. It's going to be even less than that. So the way we have to change our mindset is to think in terms of patient outcomes, clinically important for the patient. Will it make a difference? And then when you are looking at the meta-analysis, what Sri Kumaran pointed out was, what is the pooled effect estimate with the confidence interval, right? The lower limit of the confidence interval is very important. It should not cross over to the other side. Then it tells you that this is not a chance difference. This is a true difference. And if it does not cross to the other side, how close to no difference is the lower limit, the least estimate? So if your least estimate is 0.99, it tells you this is statistically significant because it doesn't include 1, but clinically is only 1% benefit. It could be only 1% benefit. Then I'm confused, because if the upper end of the confidence interval is 0.7, that is a 30% reduction in the risk of a bad outcome, and the lower limit is 1%. Now, if it is death, even a 1% reduction may be good for me. But if it is something subjective, which could be a small problem, that 1% may not be important. So we really have to define all these things in advance. then as Sri Kumaran pointed out, okay, this is the pooled effect estimate, but do all the studies show the same thing? If one is showing the opposite effect, then I can't be sure that the average, the pooled effect, is representative of all the studies. So that's why we have to look at the consistency or heterogeneity among the studies. And finally, whatever you've done, you have to contextualize it to your setting. Can I take the results from these studies and say it'll work in my situation? So this is the kind of thinking we need to have when we're looking at evidence. So what we're looking at is addressing two gaps. First is the gap between what goes as research and is published, and what you consider as reliable evidence you want to use. That is one step. And the next step is, should I then use this evidence? I may find studies which tell me something, but then can I use it? Can I afford it? Do we want to use it? What are our priorities? So that's what the whole field of research synthesis is about. Research or evidence synthesis is the process of finding and combining the results of multiple primary studies which are addressing the same question in order to generate new knowledge. So that's why it really becomes part of research, because we're getting new knowledge which can actually refute some accepted treatment, saying that this is the treatment. You'll say, no, this is not the treatment, doesn't work, or it causes harm. Or it can confirm what you know. And the tools are systematic reviews and meta-analysis. This is just a tool in the whole process of research synthesis, which can be both quantitative as well as qualitative. And systematic reviews basically are a scientific approach to reviewing published literature in an attempt to provide unbiased answers, which may be quantifiable if you can do a meta-analysis. But even if you can't quantify it, you can still glean from what you've done what information is available and what needs to be done. The key characteristic of a systematic review, as opposed to a review article or a traditional review, is a methodology section. Systematic reviews start with a methodology section called a protocol, where you have written everything that you plan to do. So that's really what differentiates a systematic review from a traditional review article. A very clear methodology section, and a very explicit way in which you're going to search for the studies, the terms that you're going to use, the databases you're going to select, and what are the criteria by which you will say, I will include this study and not include the other study, and a way in which you can assess the validity of the studies based on the methods they've done, and also when you cumulatively pool all the data, how confident am I that the pooled data can be trusted? And then the way you present the results and the characteristics of the included and excluded studies. So as Dr. Sri Kumaran pointed out, what we are trying to do in a meta-analysis is say, from all the studies I have here, on average, what is the effect of treatment A versus treatment B? So we're trying to get an average result. It's a pooled average result. But before we pool, we are giving more weight to some studies. Because in a traditional way of synthesizing information, you would say, I've got 10 studies, 6 say the drug works, and 4 say it doesn't work. The problem is, the 6 that say the drug works could have two problems. One is, it really does work in that study because it's a very large study, it's got a very narrow confidence interval, right? Then some of those studies say we don't know, they cross over. In a vote counting approach, the small studies and the large studies cancel each other out. One for, one against. So that's not a very sensible way of pooling data. So when you weight the studies, what you're doing is you're saying any study which has a narrow confidence interval automatically has lower variance, because the standard error is used to calculate the confidence interval. Right? And the standard error is a measure of how much difference there were between the results of individual patients within that study. So single study variance within study variance. That translates into a confidence interval. So if you've got lots of patients and many people had the event in question, especially the control group. So there's something called a baseline risk. If I use a drug in a population where the risk of dying from a particular disease is very low because that disease is not there in the population, right? My variance is going to be very wide. Nobody is having the event. I can't be sure. But if you use a drug in a population which is an effective drug, where the risk of dying without the drug is very high, automatically your variance becomes narrow, your confidence intervals become low. So when you have narrow confidence intervals, reciprocal of that is the weight you get. Inverse of the confidence interval is the weight to get to a study. So if you go back and look at Sri Kumaran's study, the third FAT study he referred to very often, that got the maximum weight because it had the narrowest confidence interval, which means it had low variance. Right? So that's why we need to have this pooled weighted average. So the main advantage is many studies have very small sample sizes, but in a meta-analysis, because you're pooling the results, you get a lot of power and therefore some precision. And then you can then quantify precisely what the overall effects are. And finally, as he again stressed, if you do a meta-analysis outside a systematic review, it's quite possible that you will find only results of studies which have got positive, what they call positive, it favors the intervention. That's why they get published, right? So if you just pool the results of positive studies, you'll get a positive results. So unless you find there are other studies as well, which may not have got published because they are negative, they don't show these positive results, or they are published, but they're published in some journal which is not indexed in PubMed. So unless you search for those, you won't find them. So that's the reason why it's important to look to see how much publication bias there is by making sure your methods are such that you will find all these studies. Then the second thing is you can do a meta-analysis, as Sri Kumaran pointed out, get the pooled result of 0.68 with a confidence interval which doesn't include 1. The next question is, can I trust that? How well were the studies that contributed to this 0.6, how were they done? Is there a risk of bias in those? If there is, I can't trust this result. And the next thing is that 0.68, was there inconsistency? So unless you have a methodology to say, I have to look for all these things, you're going to get a meta-analysis which is unreliable. And finally, we have to look at the contextual issues. So that's what we're going to be dealing with in the next few sessions. Sri Kumar has pointed out the very standard methods by which you do a systematic review. And then after that, you have to publish it in. So the first step is to say, I will write a protocol which I will publish. A good systematic review protocol is published either in a journal or in the Cochrane library is a Cochrane protocol, or you register it in a database called Prospero, which is just like your CTRI. You have to register all the elements of a systematic review in an international database, which is basically the elements of your protocol. If you don't do that, nobody will trust your systematic review because they don't know whether you just wrote whatever you want after the data was there, right? So a meta-analysis is an optional part, but if you're doing it, what you're basically saying is, I've got comparisons. Maybe I have only one comparison in my review, or maybe I'm comparing many things in my review, but each comparison is taken separately, and from each comparison you say, pre-decide, what are the clinically important outcomes that will affect decision-making? What are those for each comparison? And then you take the data from the papers which have that comparison and that outcome. It usually will be number of people who had the outcome among the number of people given their intervention in both the groups. That's all you need to extract. And then you decide, am I going to use odds ratios or relative risk? Once you make the decision, the program will do it for you. It'll pool everything and give you the odds ratios or relative risk. That's the meta-analysis. And then depending on the confidence interval, does it cross the line of no difference or not, you'll decide it works or it doesn't work or I don't know if it crosses. And then you look to see, is there heterogeneity? So the first step is looking at heterogeneity is you yourself have to ask yourself, looking at the comparisons in the populations, is there likely to be heterogeneity? Then you can be sure there will be. But another way of looking at it is, if the studies are all showing the same effect, what you call the fixed effect model assumes that every study's actual effect is the same. Whatever mild variations you're seeing in the observed effect is a chance variation, right? So if the confidence intervals are all overlapping, that means that there's really no heterogeneity. But to confirm that, you can look at your chi-square test with a p-value. So in that particular slide, you saw a p-value less than 0 point something, something, something. It means you're pretty sure that the difference in the results across the studies exceeds chance. It is not a chance difference. Then there was something called an I-square, which is derived from this. And the I-square of 87%, which was there in that slide, says that the differences in the results, 87% of the variation exceeds chance. Only 13% is due to chance. So therefore, you can't ignore this. That's why you will say, okay, either I have to explain the results in a subgroup analysis, where I look to see whether the randomized trials are separate from the non-randomized trials, or the biased trials are separate from this, and see what the results are in those subgroups. Or I'll say, none of this explains the heterogeneity. I will incorporate it in what is the random effects model, where you're then saying, I can't say the drugs are all acting in the same way in each trial. Each trial, the drug works differently. I don't know why they're working differently, but I will incorporate the uncertainty. So what you're doing when you do a random effects model is, you're not giving a pooled, precise estimate of how the drug works. You're giving a range of effects. And you're only capturing the mean of the distribution of the effects of each of the trials. So it's an imprecise, but telling you, if you want to look at it, this could be a range of effects you can get with the model. That's what a random effects model does. Then you might want to consider, if I change my criteria, will my results change? That's called a sensitivity analysis. And finally, you have to then decide, how am I going to present my results to a policymaker or to somebody who wants to use the review? So that's what happens. And just as an example, if you do it properly, it can really improve health outcomes and can tell you that interventions which work and which do not work. So the classic example is an article which is published in JAMA, I think, some years ago. If you look on the left of the line, what you see are a forest of horizontal lines, and that's called a forest plot. Each line represents the odds ratios and confidence intervals from 33 trials, which totally involved 36,974 patients. And these trials were done over 3 decades. And they all studied, if you give IV streptokinase or don't give streptokinase after a myocardial infarction to prevent death, what will happen? So each of those studies, the black dot in the center is the odds ratio, and the horizontal line is the width of the confidence interval. So if it crosses over the vertical line, it says, I don't know. But if you look, there are 6 studies where it does not cross, shows streptokinase works. Okay, when you pool the results in a meta-analysis, it clearly tells you that streptokinase saves lives. Now, the authors of this paper asked, did it require 33 years, 36,000 patients, 33 trials, 36,000 patients, and 30 years to come to this answer? Could we not have known this earlier? So what they did on the other side of this is a cumulative meta-analysis, where they took the first study, 26 patients, and added it with the next study of 42 patients, 65 patients, what is your pool result? And they added the next study to this pool result, and ultimately they were able to show that by 1973, when you only pooled the results of 2,430 patients, you knew streptokinase saves lives. But we didn't do that. What did the world do? They kept randomizing. In 1986, GC1 randomized 11,000 patients. And 1988, ISIS-2 randomized 17,000 patients. Expensive trials, but more damagingly, if you had been in an ethics committee in 1973 and you had already pooled those results, you probably would not have allowed these people to be trialed when half of them had a higher risk of dying. So while we were in the world of research unethically killing people, what were you doing in the clinical sphere? Pretty much the same, because if you look at the cumulative evidence of benefit and the textbook recommendations and the guidelines, including the Oxford textbook of medicine and stuff, it's only in 1980 that they started realizing, yes, we should be using streptokinase. In fact, the Oxford textbook of medicine, David Weatherall, wrote an apology saying, we are sorry, we didn't know these methods. And what were they doing instead? Recommending treatments which were cumulatively showing no benefit, potentially increasing harm, right up to the 1990s, lidocaine. So this is the reason why it is important to have a method by which you synthesize evidence in a transparent and reliable way. But there are now hierarchies of evidence, and not all evidence is considered the same. So if you look at the traditional hierarchy of evidence pyramid, all of you would have seen this. It says systematic reviews and meta-analysis of RCTs are right on top, then RCTs, then cohort studies, case control studies. Assumption here is that the top of the pyramid has least biased evidence because the quality of synthesis is better. That's the traditional pyramid. That's changed. People now say, okay, what we're looking at is filtered information and unfiltered information. The primary studies are the unfiltered information, and ways in which you critically appraise or you write a textbook called DARE or any evidence, what is it, up to date. These are all critically appraised ways in which you can present the evidence. And systematic review is again part of this. Or you can look at the 5S pyramid, which takes it one step further, where it says there are studies, and depending on the kind of question, there are a lot of primary research, then there's synthesis, there's synopsis of these, summaries which policymakers can use, and as I think you were pointing out, you're getting health systems, electronic systems. Now, if you go to Scandinavia, a doctor types in the symptoms, a differential diagnosis comes up, you put in your investigations and also gives you treatment. So the evidence is in the back end of your electronic systems. So that's what is considered to be the top of the hierarchy, which requires a lot of money and effort and updating. But that's the way systems evolve, where evidence becomes part of your everyday clinical decision-making, backed by updated systematic reviews. There are some variations. But the problem with all of this is, if you look at another way of looking at it, they'll say 1A, 1B, 2A, 2B, also looking at the same studies, but classifying it in a different way. And then if you look at it, then they start talking about various things. All of these have the same problem. They're referring to evidence about treatment, therapy, which is why RCTs are right on the top of the pyramid. But in the clinical practice, we also need evidence from surveys, epidemiology, prognosis, diagnosis. That doesn't come anywhere in this evidence pyramid. That is one problem. Second is, what we have to realize is that every question has a specific research design to answer it. So how can you say RCTs is right on top for everything? Makes no sense. And not all the studies on the same design. You can have two RCTs. One is badly done, gives you a different estimate. So how can you say RCTs are the top? There are different kinds of quality as far as RCTs are concerned. And you may not have evidence from the best design for that study. Right? All of these are already addressing internal validity from the paper. Can I trust the results of the study? It does not talk about, can I use it? So that's the other lacunae in these hierarchies. So what we are talking about in our traditional hierarchies is the hierarchy of methodology, not hierarchy of evidence required for clinical practice. So if you look at the Oxford Center for Evidence-Based Medicine, they give you these levels of evidence based from most biased, usually case series at the bottom, to the least biased, and it differs according to the question you're asking. So for an etiology question, for a diagnostic question, for a prognostic question or treatment question, there are different primary studies which will give you the best evidence, and a systematic review of those studies are considered to be the top for that particular question. And they have modified it into levels of evidence statement here in the form of simple questions. For example, how common is the problem? And it gives you studies which start from the most biased to the least biased. But what's very interesting is, at the top, step one, level one, is not a systematic review. It is local evidence, which I thought is a very good way of going. Your level 2 evidence is systematic reviews of surveys that allow matching to local circumstances. But the best evidence you can get for Kerala is surveys and data from Kerala. That is a good way of realizing the contextualization of the evidence. And also, if you look at the modification here for interventions, the top evidence can come from a systematic review or N of one trial, including one patient, being randomized to get different treatments. Acknowledging the fact that when you do a systematic review and meta-analysis, you're going from a generalization of large populations, but when you're using it for patients, you've got to bring it down to one person, saying there is a big problem in that. You lose a lot in that. So this is a modification of that. Then the other thing you're talking about, people are talking about strength of the recommendation and the evidence. They're differentiating the two. You know, how good is the evidence, but how strong is my recommendation? These are two separate things. So which brings us down to what are the current approaches to address these issues. And what we call them now are not absolute hierarchies, but conditional hierarchies. And the current way of looking at it is this diagram. I will separate it out for you and explain this to you. So if you take the old model, systematic reviews, meta-analysis on top, then RCTs goes down like that. The new model is shearing away the systematic reviews from the pyramid completely, right? And it's telling you, if you look at the bottom part, some RCTs are not as good as some cohort studies. So it says that there is no absolute cutoff between an RCT and a cohort. You can have some cohort studies which are even better at providing answers you want than an RCT. Okay, so that's the important thing. And where do systematic reviews come in this model? It's just the lens through which you're viewing the evidence. It's the way the systematic review is done that can help you to arrive at a problem from the primary studies. Okay, the systematic review is not considered gold standard. It depends on how well the systematic review is done. So when we move from evidence to policy, we need a summary of findings table from a systematic review using the grade approach, which is then used by a group of policymakers, again using a structured framework to develop policy decisions. And there is a software and a website where you can actually utilize. It's free for all of you to use. So what we want to know when we have a systematic review after that, for example, azithromycin and amoxicillin. Suppose you get a systematic review which tells you various things for outcomes. You want to know, did the systematic review suffer from any critical flaws in its methods so the results of that review are unreliable? And the tool you'd use for that is this called AmStar2. You can go to the Equator Network or just Google it, download this. It's available as a template that you can use to evaluate it. It has 16 items at addressing potential weaknesses, out of which 7 are considered critical flaws, and the rest are non-critical, but there are weaknesses. Right, so the critical flaws are listed here, and then the way they finally come to a rating is to say, if you have one critical flaw, right, that is enough to say this cannot be trusted. And if you have more than one critical flaw and a lot of other flaws, you will say, this is critically low. I will just don't even look at it. Right, so that's the first thing you do when you find a systematic review. Apply the AmStar criteria to make sure that I can actually trust this review. Once you say, okay, the methods are okay, now what do the results tell us? We want to know, do the pooled effect estimates for the clinically important outcomes indicate appreciable advantage, which means it's definitely going to make a difference in people's lives. And then that's the appreciable advantage. Next question is, how confident are we that this is a true estimate? How confident are we that this estimate will happen in our practice and that further research will not change these estimates? Tomorrow you shouldn't tell me one more trial has come, what you were doing up to now is wrong. That's what we need as clinicians. So when you're applying grade, you have to decide which are the outcomes of clinical importance to you, right? And take only the really important ones. And for each comparison, you have a separate summary of findings. And for each comparison, you take a maximum of 7 clinically important outcomes for which you have to present the relative risks and the absolute differences with confidence intervals. And then you have to add one more thing. How much confidence do I have in that result for that outcome? That's what grade does. So if you look at, say, COVID, which are the critically important outcomes, which are the non-critically important outcomes? You make that decision in advance. And you choose the critically important ones and critically important with up to a maximum of 7. So you're not going to take proxy indicators, which are usually biochemical or some values, which show you that some process is going on, but do not necessarily correlate with your clinical outcome at the end. So usually in a summary of finding stable, you only take clinical outcomes. And then from each of those outcomes, the death or improvement with azithromycin, you get a 0.6, that number. Then you ask yourself, can I trust that number? So each study is what is the risk of bias. If that third study, which carried 68% of the weight, was badly done and was biased, the whole result cannot be trusted because it carried most of the weight. Or you'll have to remove that study and see with the remaining studies, does it still show the same result? If not, your confidence in that estimate comes down. Right, you start off as high, but if you find this is a problem, confidence in it comes down. Then you look at the evidence. Does it apply to my setting in terms of the population, comparisons, doses, outcomes, health systems, all of those things? Is it directly applicable to me? If it is, you're confident. If you are not, your confidence comes down. Then you look at the inconsistency. There is some inconsistency, but I can explain it in a subgroup analysis. Then I'm confident that I know why there is variation. But I can't, and I have to use a random effects model, then I don't know. My confidence in the consistency of these results comes down. Are the results precise? Basically, it means this. If the result, you're saying the pooled estimate is 0.68. If it was upper end, definitely I will use it. But if it was the lower end, would I still use it? If I have any doubt about that, that result is imprecise. Upper and lower limit of the confidence interval should inspire the same confidence that I will use this intervention. If the lower limit is giving you doubts, there is some degree of imprecision in the result. That's one. Second is, do you have enough number of patients and events to say further research will not overturn these findings? And there is a rule of thumb. If you're looking at the number of events in both the groups together, if there are 400 events, 400 people died in both the groups together, that is enough. Or a minimum of 2,000, maybe 3,000 patients across both the groups. And you say there is enough power in this. It's a rough rule of thumb. Okay. And then finally, do you have all the studies or only the easy accessed ones? So based on these criteria, you take your critical outcomes, you do your meta-analysis and your risk of bias assessments, and then you start judging, grading your confidence in the result for each of those outcomes using these criteria. So randomized controlled trials are considered to be high certainty evidence, but for any of these reasons, your confidence can come down. You can start from high and can end up as very low also, right? Observational studies are considered to start as low because of biases, and if they're done badly, they can be downgraded further. But if they are not downgraded and they're done well, you can even increase your confidence in the results from observational studies because the magnitude of effect is so large that it's not going to change just because there are a few biases. Or across the studies, you see a very clear dose response gradient that makes you more confident in the results. Or you find that there were a lot of confounders, but if those confounders were not there, there have been an even greater effect. So these are reasons why you can upgrade the evidence from that. So what you end up then is high certainty evidence where you are confident of the results and you will say, this treatment will do this. Or you have moderate certainty evidence where you say, it probably will do it. There's some doubt. Low certainty, you say it may do it. And very low certainty evidence, we say we don't know. We're very uncertain of the results. So summary of findings table can look like this. So you're looking at COVID, suspected, critical, non-severe, at treatment at home or in hospital, one intervention, any dose or duration versus usual care or placebo. And you've got your outcomes. Death due to any cause. With usual care, you expect from this data set 22 people dying per 1,000, but with the intervention, 84 fewer people dying. That means it's a very large effect. So, but what you're also interested to know is how many studies and what was the certainty of evidence. So for each of those outcomes, you end up with this certainty of evidence with the quantitative data. That is what is used by decision makers who will then look at all of this evidence through the prism of the balance of harms, benefits, costs, burdens, and preferences, and come up with a recommendation, which could be a strong recommendation or a conditional recommendation, for its use or against its use. And this is based on overall quality or certainty in the result. So any WHO guideline or any good guideline which has used this process will say, use this in this condition. Strong recommendation, high certainty evidence. Or conditional recommendation, moderate certainty evidence. So that's the way guideline development and evidence synthesis goes. But one more caveat. If a WHO says you should be doing this, I don't think that any state should take it at face value. Because there is local evidence which must be incorporated with all this global evidence to make judgments and the trade-offs required for you to make a good health policy decision in the country. There are many examples I could give you on how governments have actually rejected the results of a systematic review because they couldn't either afford the treatment or it would take away money from their health budget into something else and cause other opportunistic harms in the treatment. So that's my caveat. There are no fixed hierarchies in evidence. It's a conditional process where you look at the certainty for clinically important outcomes and the context in which you're using it. But evidence is cumulative. And the certainty of evidence applies to the populations in the studies. And it certainly does not account for individual variations and, of course, the unknown unknowns. I've tried to give you a vast overview of this topic. It's fascinating. And if you have any questions, you can ask or email Sri or I this. Thank you. Thank you very much.
Thank you, brilliant. Thank you, Pratap, for a very brilliant and very cognitively stimulating discussion. Thank you very much for setting the stage for this, and then you complemented each other very well. I'm sure this will be an appetizer for the brains of the future researchers sitting and listening avidly. So open for discussion. Yes, sir.
Okay, I'm Dr. Ramankutti. I used to teach at Dachshund Menon Center. I have two questions, one for Dr. Tarian and one for Dr. Srikumar. I'll start with you. This is a little tangential. In my final years as a teacher, many students want to do evidence synthesis as one of their exercises, and they want to publish it like a systematic review. But I unfortunately find that universities and people higher up don't consider that as a proper exercise in research. And I'm glad that our Vice Chancellor is right here. I think maybe, especially in subjects like medicine, an exercise in evidence synthesis might be a better input into their training rather than a primary research project. I would like your comment.
I totally agree with you. In fact, I'm one of those people who is very skeptical whether a thesis should be part of a MD education, because most of the time these theses are falsified. They don't get time to do, they cook it up from the, I've had such a lot of surveys with PGs, I know how bad it is. I did my membership in the UK, I can work as a consultant in the NHS, I didn't have to do a thesis. Because what they say, an NHS consultant is a clinician. If you want to teach, you do a research degree after that. So that's one way of looking at it, that you have a stream of people, you have two streams, one who want to be clinician researchers, and you have clinicians. We need very good clinicians too. But these clinicians should pass an exam in critical appraisal. So we had to pass an exam where you read a paper or a drug company chap gives you his bump and you say, okay, I will tell you that paper where the flaws are. I used to educate drug company representatives who came with me. I'll show them the evidence. By the time I finished, they stopped coming to me. But as far as the first question is concerned, MCI now recognizes.
Oh, really? Okay.
Yeah, they brought it back. Systematic reviews can, one systematic review can be considered for promotion in your early stages of your career.
I see. I think the university should strongly consider it for postgraduate thesis also. I mean, that is my request. And so of course, the question to Dr. Srikumar is very simple. So the way you presented it, I would imagine that a situation where a fixed effect model is justified would be rather rare, isn't it? I mean, how does it work? Like, I would imagine that most situations where you are taking studies from different situations, probably they are not looking at the same truth. So are there, I mean,
okay,
what proportion of situations would be there where fixed effect model is really justified?
Yeah, it's that is what it's Pradap said. It's if you get very much overlapping confidence intervals, you don't have to go for a random effect model. Or other way, I would say, even if you go for a random effect model, it come out back as a fixed effect measure. Okay. That is what it happens.
So, sir, this is a question which often comes into when we are doing a review. Because if you look at the handbook, it tells you very clearly you should start with a random effects model, right? The only situations where I would differ is if you're doing a drug trial, if you're looking at a drug, and all the drug trials have been done by drug companies, very rarely will you find heterogeneity because of the methods. They're very similar methodology. And if there's heterogeneity, it will be because you'll find the manufacturers were different. Sometimes you find that the manufacturer of the drug comparisons are different, you'll get opposite results. But there are other people who would say you can use both. If you find that heterogeneity is slightly high, say going around, I square is going to 45 and all, there is no gold standard of 50 or 30 or something, then you can change your model and see, does it make a difference?
Okay, so one more caution here. Sometimes people use it, I mean, they already have in mind, this is what I wanted. So if it is random effect is no, fixed effect is not giving that, go to random effect. That is very dangerous. It's many times it happens like that. So critically, you are outside, you have to look at it.
Sir, you want to say anything? I think there is a message from the organizing committee. Are we running short of time? Yes.
Yes, running
so
short of
let
time.
me, on behalf of Professor Sharma and all of you, thank both of them for a very, very stimulating session. Thank you, Pratap and Professor Srikumar Nair. Thank you.
So it's time for the lunch break. We have all are requested to reassemble by 2 o'clock itself because Dr. N.K. Arora will join us online to share the experience of COVID vaccine delivery platform in India, challenges and way forward at 2 p.m. itself. Dear delegates,
Hello, Amit, what is the problem? He has joined in, but he has become out. Kindly log in again. We could hear his voice. You please. Oh. Okay, okay. Please help him. Okay.
and adult physicians, that means general physicians, pulmonologists, endocrinologists, cardiologists, neurologists were drawn into those networks right from national level to state and to the district level. And trainings were done. And trainings by the 4th week of December, AEFI training was completed and it was taken up in parallel like a army-like operation. And this led to what one would say that usually it has happened in past that India has introduced a new vaccine usually after a gap of 5 to 20 years. But this time it was a gap of 5 weeks. The global vaccine rollout took place for COVID on 7th December and we rolled out on 16th January. So there was a major achievement of sorts. Now coming further, you would have noticed that initial 2-3 months there were a lot of rumors, misinformation about vaccine efficacy and safety. But since the program was already planned, it was not reactive, it was responsive. And you could see that by the end of March or April, the negative news about vaccine gradually diminished. And this is the reason that today we have a vaccine coverage which is one of the highest in the world. And 92% adults have received both the vaccines. Here I forgot to mention one thing, and that was prioritization. Vaccine was obviously in short supply. So prioritization was done somewhere in October. And we followed national the WHO guidelines, but also the national framework was also kept in mind. And so that when it was rolled out, it was a clear-cut roadmap, physicians, frontline workers, then 60 plus, and then 45 plus, and then finally 18 plus. And children were not taken up because, as the evidence had shown from first year, that children are not very much affected. And during the whole program, you would have seen as the vaccine availability improved, the uptake was excellent. And it was 21st June when we knew that vaccine availability is going to be now sufficient. And thereafter, you saw that every day 8 to 9 million individuals were immunized. And the other important component throughout this COVID experience has been the strengthening the health system. I'll not dwell too much on that. But one important issue I want to share, that what should be the schedule of vaccination. Co-vaccine, there was clear-cut. It was about, it was 4 weeks interval between 2 doses. But there was lack of clarity to begin with about Covishield. And it was, to begin with, it was 4 weeks. We increased it to 8 weeks. And then it became 12 to 16 weeks. And we used the available evidence to make the best choice. There was a lot of pressure, both from academia, from professionals, from press, that it is basically to save the vaccines. But the fact of the matter was that it was science-based. And as a result, what we saw, that we are doing the data analysis, this vaccine, Covishield vaccine interval between 12 to 16 weeks actually helped us, because the second dose almost worked like a booster. And thereafter, from January onwards, a vaccine has been introduced for children. And now we have a heterologous booster also. Here I would like to also share that we are having 2 new vaccines, made in India vaccines. One is mRNA vaccine, which is going to be getting emergency use authorization soon. The other is intranasal vaccine. These are unique in their own side because mRNA can be stored at 2 to 8 degrees. No other vaccine mRNA is 2 to 8 degrees. Then we have the world's first DNA vaccine. Unfortunately, they came up so late that it could not be introduced in the program, but I understand they are exporting it now. And then this intranasal vaccine, which is both will be available, both as heterologous booster as well as primary. And as far as mRNA, there is a new version. Omicron specific vaccine is also under development. By the end of the year, it should be a sea change in the whole vaccine ecosystem of the country. And today we have all the available possible platforms where vaccine can be manufactured on one side. The other important thing is that from a vaccine manufacturer, we have become vaccine developer, R&D. And I'm sure in future, lessons are emerging, that given a challenge like COVID, we are very much capable and resilient to convert it into an opportunity. And the second thing which we learned from this whole exercise was that now better vaccines and newer vaccines using indigenous platforms would be possible. Another good news I would like to share with you that by the end of this year, HPV vaccine will also be rolled out for our daughters and granddaughters, 9 to 14 years. And that is again with a Made in India vaccine. So all in all, it has been an exciting journey. There have been lessons, and lessons particularly that if we have to take the leadership role, infrastructure investment is necessary. And India did infrastructure investment. Now we have our own assay labs, animal testing labs. There is need for upgrading them. And similarly, field sites, 11 field sites have been established to undertake clinical trials of this stuff. So all in all, there is a lot to be kind of proud of, but it has also given us a lot of lessons. But one important lesson is that political will at the highest level is extremely important, because all these activities require resources. And if resources are available, the tide can be turned in our favor rather than against. Thank you very much. I will be happy to take a few questions if audience feels.
Thank you very much, sir, for this very brief and elucid
Organizers,
the vaccine scenario.
am I still there, or you are not able to?
You are there.
Hello. Were you able to hear me?
Yes, we can hear. You are mute. Kindly unmute yourself.
Dr. Rajmohan.
Yes, sir.
Does anybody want to have any clarification?
Yeah. We will just give 2 or 3 minutes for questions. Any questions? Any questions? Kindly. Sir, everybody is now concerned about 3 issues. One is about the number of booster doses. There is a complacency in receiving booster dose, and the initial enthusiasm is not felt now. That is one issue. Then second issue is about the heterologous, the vaccine issue. The heterologous dose also people are concerned. Then about reinfection, the issue of adverse events. A lot of issues are there. So what do you think about the booster number of optimum booster doses? People are getting 6.
So I will try to answer these 3 questions. So first of all, we must understand the vaccine efficacy has 4 components. One is prevention of infection. The second is prevention of symptomatic infection. Third is prevention of severe disease. And then fourth is prevention of death. Unfortunately, none of the vaccines anywhere in the globe prevent infection. It is reduce symptomatic infection, but the most important thing is that the major impact, which is over 90% efficacy for severe disease and death. And our vaccines are also so good, number one. The second is our population had, there is a hybrid immunity of our population. A lot of people, or almost all, or over 90% people are infected, plus vaccinated. As a result, there is no need for multiple boosters. There is no need, it appears at the time. But the current booster or precaution dose is useful, and heterologous, the Carbovax heterologous, we have reviewed the data, it is very safe and very effective. And it produces almost similar immunological response whether you have received primary as Covaxin or Covishield. The incoming days, booster for intranasal will also be available. And same is true for mRNA vaccine. And initial, whatever data we have seen, the key issue is safety, and there is absolutely no kind of should be concerned. And immunologically also, these heterologous doses are very good. Thank you. I'm so honored to be invited in this to talk to this August audience. Thank you very much. Thank you very much.
So we can continue with the next session, research communication and knowledge dissemination. So we have with us Professor K.R. Thangappan, former professor and head, Achithamenon Center for Health Science Studies, Thiruvananthapuram. He will talk on unbiased and usable reporting of research finding, publishing, presenting, and submitting reports to research sponsors. I invite Professor Dr. Vijay Kumar, professor and head, former professor and head, Community Medicine, Government Medical College, Thiruvananthapuram, to chair the session.
So, good afternoon, everybody. It's a nice time to sleep. But Dr. Thangappan, my close friend, is determined to see that none of you are sleeping. Dr. Thangappan and myself is really working together in this field for so many years. And he is considering the number of publications and his presence in the field of public health in Kerala and maybe in India itself, is the right person to tell us the importance of dissemination of any sort of research that we undertake. We should understand that any research, whether it is successful or even failed one, each of them will have social, political, and economic bearing on the result. And let us hear from Dr. Thangappan about the importance and the methods or maybe the issues associated with that. Over to you, sir.
Thank you, Dr. Vijay Kumar. I will try to be very brief, try to save some time because we are already behind the schedule. So my topic is reporting of research findings. Yes. Okay, thank you. So why do you need a report? I think we have various purposes for a report, usually for documentation, dissemination, and sometimes it is mandatory to make a report if it is a funded research, or even otherwise sometimes. So these are some of the types of scientific writing, proposal writing, research report, journal article, letter or short communication, review article, and chapter for a book. So when you write for journals, these are some of the basics. Do not change design. It has to be, whatever design you started to conduct the research, that has to be kept always. focus your message, state your limitations, curtail your expectations, which means once you submit your article to a journal, most likely it will be returned. So it has to be probably submitted to several journals before it is published. Be ready to accept criticism. So I have seen many students who once you see the criticisms by the reviewers, then they are completely dejected and they don't continue to publish. That is not the case. Lots of criticism will be there by the reviewers. We have to accept the criticism and revise our paper based on those. Be prepared to modify your article several times, maybe 20 times. We don't know how many times, depends upon the article and the journal. So these are some of the basic writing style. Use the language potential to the extent possible. The language is very, very important. I think you have to use it optimum so that it is communicated very effectively. As I said, revise maybe several times, even before the first submission. Very, very important. And read it. Maybe your colleagues also can read it. Read and learn from good work. I think this is something which I have seen missing from many of the students and young researchers. So when you read an article, please learn how it is written, each aspect. It's very, very important. So that we can also take lessons from that article and maybe try to implement some of them in our article. Usually active passive voice. This is very important. The voice, which tense are you using, and the voice, which are, I think sometimes journals insist that you have to use active voice. Briefer, the better. As you know, in many papers, there's a limit, maybe 2,000 words, 3,000 words. So unless you are able to write very briefly, it will be very difficult to communicate scientific information. Make the paragraph the unit of composition, particularly in the discussion session. Use consistent tense and spelling throughout. If you are using American English, it depends upon the journal. So they will insist, I think, if that to be consistent. In some part, it can be British English. In the other part, it cannot be American English like that. That has to be kept in mind, I think. So I will focus only on the format of reporting research findings to a journal. So other formats I am not reporting because there is no time. First of all, the title. Why the title is important? Better to indicate the study design in the title, such as cross-section survey, case control study, randomized control trial, etc., in the study title itself. So people will be able to understand what kind of study is this one. Follow the guidelines from the journal regarding number of words in the title. That is also, nowadays people will not, the journals will not accept. It's an online publication. If even if a single word is more, they will not accept. They also require, some journals require short title in addition to the long title, because that has to be given at the end, maybe top of each page. Abstract. This is very important for any article. An informative and balanced commentary, summary of what was done and what was found. That is the crux of abstract. Usually it is structured with a limit of 200 to 300 words. And in the structure is usually called IMRD format, introduction, methods, results, discussion. Slight changes may come depending upon journal. Strictly follow the guidelines from the journal. It's very, very important. Submission may be sent back to the corresponding author if the guidelines are not followed. So that's again another time delay. So it is very important to follow the guidelines. Usually, only the abstract is read by the journal editor to make a decision to reject or to send for peer review. So that is why abstract is very, very critical, very, very important. Because after reading the abstract, they will reject, or probably they will decide whether it has to be sent to peer review or not. All abbreviations should be expanded when first used in the text, even in the abstract. Usually this is a major mistake. People think that these are, because these reviewers and editors are maybe from different fields. They don't know many of the abbreviations. So if they don't know the abbreviation, it's something like there's a tendency to reject if they don't know what is written there. Use a standard writing style, there are different styles. BMJ style is one, so use consistent style so that it is communicated very effectively. Keywords. This is also very important. Keywords capture the essence of your paper. They make your paper searchable. So once these keywords are used, your paper should be immediately coming out from any search engine, so that the citation of your article is small. Include your methodology. One of the keywords can be methodology. Avoid single words. So keywords means each keywords can be 2 or 3 words. Focus on the main topic. Avoid overlapping keywords used in the title. Some journals insist that words used in the title should not be used as keywords. So that is because the title is already there. So there is no need to repeat them in the keywords. Again, follow the guidelines regarding how number of keywords, etc. Perform keyword search before submitting. You develop your own keywords and try to search in the website which are the journals coming out, articles coming out from there. So that will be an experience. Introduction section. After this one is the introduction. This is the scientific background why the research topic is important. Probably after abstract, I would say this is the most important section of any article. It has to be a comprehensive review of literature, and gaps in literature should be identified. Recent systematic reviews, meta-analysis will be useful references, and go to these references within those systematic reviews or meta-analysis to identify the original research and read them very carefully. Look at the cross-reference, that will be very useful. Use recent literature. Some journals insist only use the last 10 years, unless it is a very important article published 20 years, 50 years back. Otherwise, always better to use recent literature. For example, if we present data from the SRS, sample registration system in India, use the latest one. I have seen people using 2 years back, 10 years back SRS. When we are writing some article now, you have to use the latest. It is available online, and the reviewers, it is available for them. So they will see that this is not the latest SRS, infant mortality or life expectancy, etc. you are using. Then next one is in the introduction, rationale for your investigation, usually to fill the gaps in literature. I think this is usually missed in many of the introduction sections. The most important rationale for your study to be published is that you are trying to fill some gaps in the literature. And you have to convince the editors and peer reviewers that we are trying to fill some of the gaps in the literature. Otherwise, there is no need for the study. So that is very important. So even in the abstract, when you write this, probably the first, if there is only one sentence, we should focus that one sentence on what is the gaps in the literature. And then introduction should end with an objectives, major and minor. So that will be the introduction section of an article. Then go to the method section. I am going through that same format, IMRD, introduction, methods, results, discussion. Study design, what kind of study design did you use? Whatever study design used, that has to be mentioned. There should not be any change in the design as I mentioned earlier. Setting, locations, relevant dates, ethics approval, periods of recruitment, registration, exposure follow-up, and data collection. I think ethics approval date is very important, because if your study is done before the ethics approval date, nowadays usually the journals will ask for the date of approval. If you started the study, you may not have started, But if you write like this in the journal, that is the most important reason for rejection. Which means that you started the study before the ethics clearance. It may be unknowingly you have written. That is a very critical information. Then participants, eligibility criteria, sources and methods of selection of participants regarding the participants, variables, clearly define the outcome variable. Outcome variable is the most important. And other variables clearly define how did you measure, how did you operationalize them for your study. It's very important. Sources of data, if you use some other sources other than your primary study, that has to be mentioned. Bias, describe any efforts to address potential bias. If any selection bias, that if you identify, you anticipate any bias, that has to be described in the method section. Sample size, describe sample size estimation, what power, etc. For example, if it is a cross-sectional study, you don't need to write the sample size, for example, n is equal to pq by the square, etc. That is not required. But what was the anticipated prevalence? And where did you get the source? Put a reference. And what precision did you use? Precision means half width of the confidence interval. So that these are most important information for the sample size estimation. That only needs to be given in that section. Quantitative variables, how did you these variables were handled in your collection of data and analysis stage. Very important. Statistical methods, methods to control for confounding, any analysis for subgroups and interactions, how missing data were handled, any sensitivity analysis. Missing data, for example, you said in the table total, you have a sample sizes, for example, 500. But in all the other sections, when you add up the samples, it is only 480 or something. What happened to the 20? So I think we have to make sure that if there is some missing data that has to be reported somewhere, so that while the tables are read or the articles are read, the readers will understand all the entire data is analyzed. Then coming to the results section, participants report the numbers at each stage of the study. There may be some difference because if you collected 500 people, but some of the information, 500 will not be available because that may be missing. So that information has to be communicated. Reasons for non-participation at each stage. How many people participated, how many you approached, how many participated, why they did not participate. That reason has to be given. Use of a flow diagram will be useful for the recruitment of participants. Then coming to the descriptive data, characteristics of the study participant and exposure details, a number of participants with missing data for each variable. Each variable information may be missing. For example, economic data, socio-economic data. For example, they may not report the income. So then that may be missing in some cases. So that missing data has to be written. Outcome data, outcome variable, very important. Report number of outcome measures. If there are more than one outcome variable, it has to be specifically written. Then start with the main results. Unadjusted estimates and adjusted estimates, including 95% confidence intervals, very important. If you use a 95% confidence interval, no need of a p-value, because people think p-values are the most important thing. No need to write p-values if you are using 95% confidence, unless journals insist on that. And other analysis, if you are using some other analysis other than the main outcome variable and secondary variables, you have to report those results. So in the discussion, maybe we can start with the key results of the study based on the objectives. Then the interpretation, interpret each of the study findings and relate to previous findings. How is your finding different from the previous finding? Why did you find a different result? And implications of these findings can also be discussed. For example, we in Achyuthamenon Center, we recently did a study on, and I think a state representative sample of NCD risk factors. We found that the hypertension control in the state of Kerala is only 12.5, 12.3 or something. Very, very low. In a state like Kerala, where medicines are freely distributed and a highly literate state, the awareness levels are very high. Why it is so? So this is the point you have to discuss. Because Kerala is probably, comparable to many European countries in health indicators like infant mortality, life expectancy, etc. But if you compare the control rates of hypertension of 12.3, where are we? Canada has a hypertension control rate of 65%. Most developed countries have hypertension control rate of more than 50%. Why we are having only? So these are the things we have to highlight, why we are having this low rate of hypertension control. It's only an example, I am saying. Similarly, other results also will have to be discussed. And the generalizability, discuss the external validity of the study findings. We have done a study only in a small panchayat in Kerala, maybe also out of the 1,000 panchayats. That cannot be generalizable to entire state of Kerala. So why it is not generalizable? If it is generalizable, your justification, etc. will have to be written. As I said earlier, limitations very important. Consider sources of potential bias, direction and magnitude of potential bias. How you try to address some of this bias in your study. Conclusions and recommendations. Conclude the report with the major findings of the study. Recommendations should emerge from your own data. So it has to be from your own data, not from what you think. It is a recommendation. Usually recommendations reported based on what you think it is the best for the study, best for the state or the country. That is not the case. It has to come from your own data. Limit the number of recommendations. So it's only one study, as probably you have heard in the previous meta-analysis, etc. There are several studies. Then only policies can be made. Your study is only a single study. You cannot have too many recommendations. References, very, very important. People think it's not a very important. This is a very important aspect of any study, and people will, journals will definitely look into these references. Very important. Journal guidelines has to be followed. If referencing software is used, make sure that accuracy of references. Some software is there is little problem, then the entire referencing style will be gone. You have to make sure manually that it is correctly written. Limit the number of references as per the journal. Make sure that the citations in the text actually match with the references included. Some of the times what happens is you have a citation in the text 30, but actual reference is only 25. What happened to the 5? And also when the reference is very important, the initials. The initials, you are changing the initial letter means you are changing their ancestral records, etc. That is not correct. There are some other items to be reported usually in the journals. Funding, very important. Where did you get funding? Report all sources of funding. If there are guidelines for reporting by the funding agency, follow that. Role of funding agency may be stated, very important. Whether is there any influence by the funding agency on your report, on your article? That has to be specifically mentioned. Conflicts of interest. Report if there is any conflicts of interest. Use the form for reporting conflicts of interest by the concerned journal. That is also very important because this is particularly industry-related articles, drug-related articles are very, very important. Other contributions, this has become mandatory for most journals now. So ideally, if you have not contributed sufficiently to the article, you are not eligible to become an author. In many institutions, and if you give an ethics clearance, then they insist that one of the members should be included as an author. That's not correct. That is not acceptable also. Ethics approval from all participating institutions, very important, and Health Ministry Screening Committee approval if any foreign researchers are included or if there is external funding. If external funding itself is there, there is no researchers, there is no data sharing, even then Health Ministry Screening Committee clearance is required for those kind of research. Again, I think, make it brief. The examination of, for example, examination of physical acuity in the subjects did not yield any negative results. Subjects had 6/6 vision, very simple. High BMI was much more prevalent among females than in males, though in both sexes the proportion of normal BMI was negligible. Most people had high BMI. The proportion with high BMI was higher among females compared to males. There are some examples of making it brief. Use the active voice whenever possible. All subjects were subjected to blood pressure measurement. We checked the blood pressure measurements of all subjects. The interview schedule was administered by trained investigators by visiting the houses of participants. Trained investigators administered the interview schedule by visiting the houses of participants. These are very briefly the important points in communicating our research to a scientific article, scientific journal. Thank you.
Thank you, sir. It was a lucid presentation. It's actually a topic which requires a lot of time, which with his experience and expertise, Dr. Thangappan has focused on the key elements. He has actually focused only on the publication in a journal, but we should also consider that when we discuss about dissemination of our research finding, we should go beyond that. Maybe online books, or maybe these sorts of dissemination through these sorts of conferences and sharing with the policy makers. So there are so many dimensions to it, but all of them cannot be dealt with the limited time. It was a really lucid presentation. Thank you, sir. If there is any questions, we can.
So we can have the question session at the end of next session. Now we continue with the next session. Projects not completed, completed not published, published not disseminated, and not translated. Why all these are not ethical? So now we have with us Professor Dr. M. Narendranathan, former professor and head Department of Medical Gastroenterology, Government Medical College, Thiruvananthapuram. And I request Dr. Ramadevi S., retired professor, Medical Sociology, Government Medical College, Thiruvananthapuram, and Dr. Professor Sujamol Skaria, Dean Faculty of Nursing, Kuhas, to chair the session. Over to you, ma'am.
Good afternoon, all of you. Professor Dr. Narendranathan needs no introduction to this august audience. Besides being an expert clinician, he's a good researcher, clinical epidemiologist, and he is updating his knowledge every day, as far as I know. I think he is the best person to talk on ethics, considering his vast experience in this area as chairperson of several ethics committees, and he is an expert in ethics. So, over to you, sir. We are eager to listen to your presentation.
Thank you. So I'll straight away go into the subject. I was asked to talk about ethics of research that is unfinished, it may be unpublished, and untranslated research. Before I go into this, let me ask a question to all of you, which is the wealthiest place in Trivandrum? If you're asked to find out which is the wealthiest place in Trivandrum, I'm sure many of you would say it is the Padmanabha Swami temple. There is the B vault in the Padmanabha Swami temple. But I think I have got a different take on this. You know this building? This is the medical college office. Inside the medical college office is the library. And inside that library is the CD rack of postgraduate students. Thousands of postgraduate students racks, that is 10 to 20,000 years of work of postgraduate students are lying there, unsung, unheard and unwept. And I think that is the wealthiest place in Trivandrum. That would be my take on that. Why is it that these researches are not published? I remember a saying from Upanishad, which says that a student can be compared to a donkey carrying a sack of gold. The donkey knows only the weight of the gold. It does not know the value of it. And that's exactly what is happening to our postgraduates and the people who do research. They come out with the research, but they are not publishing it because they don't know the value. They know only the weight, the problem, the trouble of getting the research. So that's it. Our postgraduate theses are the result of this, and there are many of them are like donkeys carrying a sack of gold, who know only the weight but not its value. If you look at the World Medical Association Declaration of Helsinki on publication of research, it shows that the research has to be communicated. Without this, research is unfinished. The time, energy, and money spent should not be wasted. So if you do a research, it should be published. So if it is not published, it is not done. Authors, editors, publishers, and sponsors all have ethical obligation with regard to the publication of the results of research. It's a very important thing. Authors have a duty to make publicly available the results of their research and are accountable for the accuracy of their. This is what is given in the World Medical Association Declaration of Helsinki 2013. Another thing is that, what about negative results? There is no need for you to cling on to negative results. People should know about it. Negative results do occur on excellent studies. This should also be published. And then the source of funding, institutional affiliation, and conflicts of interest should be declared in the publication. And then reports of research not in accordance with the Declaration of Helsinki should not be accepted for publication. So these are the statements about the World Medical Association on the declaration of, on the publication of research. I would like to point out here about the Marine Product Export Development Authority, Indian Seafood. There is an office of MPDA in Cochin. One of the best research that I have done was actually for them. The Cochin the Marine Product Export Development Authority approached us, said that the prawns they were exporting to Japan and to other countries are dumped in the sea because they contain cholera bacteria. So they told us, why not you go, and possibly it is the peeling people, the people who are peeling the prawns who are having they are having the cholera bacteria. So why don't you go? So we, three of us, I think Dr. Gopalakrishnan, M.O. Varghese, Dr. Abhayambiga and myself, we went there to investigate. We did a very systematic research, and I'm sure that it is one of the best researches that we have done. We pointed out the exact source from which the cholera bacteria came. It was from the water, they have taken pools of water and made it into ice. And thus, we made a good contribution to the Marine Product Export Development Authority. When they changed the source of ice, this could be stopped. But they requested us, can you please not publish this? So we agreed. So I think that there is I think that we have to accept that. And you know that thing, this is what happened about there is a very good research which was done on H5N1 flu, hypercontagious bird flu. You know what the US panel defense recommended to censor this, that the study should not reach the public. They said that this will be used for bioterrorism. So they said don't publish. So there are certain situations where good research may not be published. But I think that you look into this, the scientist voice fears, that about 30%, 29 to 30% of the research done in US on clinical trials were not published 5 years after it was completed. And you know that they have taken, the study was done on 2.5 lakhs of people. And they have taken on the informed consent, was told that the research may benefit the society. But I think it is unpublished and training there. So this is the problem with unpublished research. And then I think why is it that papers are not published? What may be the reason why these are not published? One, that objective is the degree. Today morning I heard a very interesting statement by the secretary saying that thesis is a niche activity. Yes, the objective is the degree. Once the degree is there, you're okay, no need to publish it. That's one of the reasons why it is not published. And second is that lack of time. And once you pass your MD, you get into a job, you are busy going around with that, teaching and practicing and things like that. That is another thing. And third is not confident of the results. This is one of the sad things about many of the research that we have done. So I think we'll not go into that thing. One of the things which I find is that many of this, I was the chairman of the ethics committee of the in the Toronto Medical College, and you'll be sad and depressed to see the thesis which are the projects which come to you. They have written the subjects were selected from the outpatient, and out of this, why should you write it in the past tense? Which means that this is actually, many of our theses are not theses, but they are Control C and Control V. What else is there? It's just Control C, Control V research. So, and it is not in one research. This is the student submits that paper, forwarded by the head of the department, comes to the ethics committee for clearance. Control C and Control V. What is this? And this is, then how can they go and publish this result when it is there? So I have a suggestion for the for our Vice Chancellor, that if there is all the postgraduate theses should be available in a database, and they should be able to check the plagiarism using that thing. If there is a new thesis, they can put it in and see whether there is plagiarism because of the old studies that has been done. This is something that is highly essential, that otherwise we are degrading our own research. And it's very sad looking at this research and giving it clearance for this research. And then incomplete study. Why? One day when I asked the postgraduate student, why you didn't publish it? That there were 20 controls were required. I got only 10. So I'm not very sure. So that's why I didn't publish. So these are the things which come to these people, and they say the study was incomplete. And then the another thing is that co-authors. So when I gave this thing, the pathologists were not happy. The radiologists were not happy and things like that. So these are many of the things which come, and the paper remains in the CD rack of our office. There is one of the, and then another major reason is that about 50 to, it is said that in institution 15 to 85% of the papers are actually submitted for publication, and then some of them are rejected. Why is it that they get rejected? One is that it may not be relevant to the journal, because you have to choose the journal wisely. The guidelines are not followed. Plagiarism, I think that is one of the important things, and then it's essential that we avoid plagiarism. And then you may find that similar things are available in the, similar articles are already there So they will write saying that we are happy that you have submitted the journal, but similar studies are done elsewhere. There is another important thing. And bias, is bias an important thing? When you send an article, let me share a personal story with you. It's personal, I think it is relevant here. Recently, because my daughter is an economist, I authored 2 articles along with her, and one was published, and then the second article is under consideration. A third article, which I thought was a very unique idea which I had, and so my daughter told me, you be the first author because it's your idea. And it's an excellent idea. When I send it, gastroenterology, professor of gastroenterology, talking about opportunity-driven entrepreneurship and its relation to economic development. I think that one of the reasons why they didn't is because of the bias involved in the thing. And gastroenterologists writing about economics. So I think that our citations, our contributions, and our qualifications may all count in it. But one of the things which I would like to say is that it's about my MD thesis. My MD thesis was on Odalam poisoning. And I was helped by Professor Krishnadas, Dr. Vijayaraghavan, to excellent teachers. And I think Professor Krishnadas took me in his car so that I could present my thesis in Bangalore. You know, that thing, this paper, this thesis, which was published in a Journal of Association of Physicians of India, is quoted. 2 years back, I found that it was quoted in the FDA poisonous plant database. On the point, my thesis was on Odalam poisoning. So it was a good thing to know that our thesis, which I did years back, and with the published in the Association of Physicians of India, is quoted by the FDA in plant database. But even now, a few months back, we had, there was the Indian National Association for the Study of Liver, conducted the annual conference. They invited papers from all over India. They wanted that they wanted to select 5 papers for the Young Investigator Award, and all these 5 people will be awarded. And do you know what happened? 3 of these 5 papers were from the Medical College Trivandrum. So this I thought was a great thing, and I am standing there on borrowed plumes. And then another thing about publication of research, you see that in antidepressant drugs, 74 approved drugs were there. And out of this, there were 36 negative studies and 38 positive studies. You know that out of the 36 negative studies, only 3 were published. And out of the 38, 37 were published positive studies. So this is another publication bias which occurs. Negative studies are not published either because you don't send it or it's not accepted, we don't. But an interesting thing came out of a research done later. They found that industry-funded research, 85% of the thing gave positive results, whereas if it was government-funded, only 50% gave positive results. There may be many reasons why industry-funded results give positive results. The trials are flawed by design because they use a poor comparator. Suppose they are coming with a drug, they use an inadequate existing drug with an inadequate dose, or they may use a placebo and then show that their drug is good. Or they may select subjects who are ready to get better. This is another important thing. Or if do an interim analysis, and if they found the drug is bad, they either stop it or change the design or something. And they don't publish negative results. This is about negative not getting published. What about the other study? You might have known what I am talking about here. This is the autism paper. You know that a fabricated, falsified paper submitted in Lancet. Nowadays, sometimes I feel that Lancet, is it political journal? Sometimes I have felt. This is the author of the infamous paper who said that MMR vaccine is linked to autism. This paper was going around, and after 2 years, the investigation for more than 2 years found that this author was guilty of conflict of interest as a recipient of money from the lawyer looking for the link to the vaccine and regarding the company setup looking to market the test. So this was a false, bad research. You know, you might have heard about Markham Pierce. You know that he's a gynecologist. He was an obstetrician at St. George's College, London. And he reported that when a person came to him with an ectopic pregnancy, he took the ectopic pregnancy, reimplanted it into the uterus, and the patient got better. And so this was a very, a great discovery. But many of the students, many of the people who are there, they couldn't realize this happened in our hospital. How did it happen that I didn't know about it? He had fabricated the case. It was a completely fabricated research. He was struck off the General Medical Council. But another interesting thing about this publication, Geoffrey Chamberlain. Geoffrey Chamberlain is the editor of the Journal of Obstetrics and Gynecology. He was a well-known ultrasound specialist, And Malcolm Pierce made him a co-author of this article, even though this was a gift authorship which was given. So Geoffrey Chamberlain accepted it for publication. So this is another important thing which can gift authorship. He was reprimanded by the GMC, but he was not struck off, said that it was a considerable error of judgment. So whenever you are accepting a gift authorship, think of these things. Another thing, in relation to the ectopic, but today morning, we saw Dr. Ramanguti discussing about the people who are so much against abortion. They are so much against abortion. So there is a new law about ectopic pregnancy. Sound better. I'm sorry for the. This is an audio file which I thought that. It shows that the Ohio. In the Ohio, they came out with a regulation that in ectopic pregnancy, if ectopic pregnancy is there, and if you abort that fetus or if you remove that fetus, you can be punished for murder, and that a gynecologist should reimplant the ectopic pregnancy into the uterus. It came in 2019. Can you imagine that? This was the reason what happens when politicians make laws, make policies. But I think that you may have known the later on developments. But, so these types of can occur when such wrong papers come to the, get published. And then, whenever there is a research, there is always a gap between the bench and the bedside. And this is what we call the translation problem, bench to bedside. I'm sorry, I think it is. You know that the answer is 17 years. Do you know the answer for what? What is the time lag between translational research? It is known that if you do if there is something is found out in the lab, by the time it takes to come to the bedside is 17 years. That is the time lag between bench to bedside. And then these are the 5 stages of translational research. One, basic science research, which is called the T0 research. And the other one is translation to the humans, where healthy individuals, you do the research. That's called the T1 research. And then do the T2, translation to the patients. This is pre-approval research. And then there is the post-approval research called the T3, translation to practice. And then you see what is happening to the community. That is T4, translational research. so these stages of research, you might have heard about Peter Tugwell. I think when I was doing my epidemiology in North Carolina, he was actually in the McMaster University, and he was given the received the CIHR, Canadian Institute of Health Research Bearer Flood Prize Award for he was the person who came out with the idea of translating research, and he also came out with a very interesting loop called the measurement of it, the iterative loop and its measurement. So first, I think this is an important thing. You should define the burden of illness. Once you define the burden of illness, you should see what is the causation of what causes the thing. And then you come out with an intervention and see whether this intervention will be acceptable in the community. And then look at the efficiency of the problem and the synthesis, how it can be done, and how you can monitor the program, see the assessment, and then again the burden of illness. What I may have showed this slide is that it is essential that we define what is the burden of illness. Now, recently there is a big dog menace in Kerala. What is the problem here? Is it rabies? 20 people died of rabies. So why many of the people are suggesting that the policy for stopping this is vaccinating the dogs. You catch the dogs, vaccinate them. Does it solve it? What about dog bites? What about the problem of stray dogs? So it is highly essential that you define the problem. Defining the problem, the stray dogs in the streets, if you define it as rabies, this is your solution. But if you define it as dog bites, different. If you define it as stray dogs, the number of stray dogs, it is a different solution. This is an important thing. It's highly essential that we decide what is the problem and define the burden of illness. If you vaccinate a dog, does the dog become very decent, stop biting people? So people think that once you vaccinate the dog, that's it, it solves the problem. Is it? A vaccinated dog is a very decent dog, doesn't bite people. I think that's, so we are looking at the we are looking at the problem in a different perspective. This is one thing that we all should know. Define the problem for the people. And then you know that the NGO, the government asks us to find the solution for this. And then let us see what happened in Netherlands. Netherlands became the first country to have no stray animals in its streets because it came out with a problem called the CNVR, catch, neuter, vaccinate and release. But in India, Goa has become the first state to be free of rabies. They also have a very good program of catch, neuter, vaccinate. This is another important thing. So we should learn from them. And there is a theory, which I am wrong in saying this thing, that this is another thing, lockdown. In the lockdown, why is that the dogs start biting people now? Is it that it was already biting people, we started hearing about it now? It has been said that when there was a lockdown, the number of eateries were closed, there were no fast food shops, the dogs did not get any food to eat, so they started biting people. Maybe a good thing. This is something that we have to look into, see whether it was the reason. So this lady has come out with feeding India's street dogs in lockdown, give them that thing. So the problem is not just vaccinating the dog. We have to define the problem. It is translational research which can identify it and then come out with a solution. And translational research is not risk-free. You should know that the most significant ethical issue in translation research is making the research less rigorous. We heard Dr. Arora saying that they developed a vaccine in 5 weeks' time. Are you worried about it? A vaccine which usually takes 5 years to develop was developed in 5 weeks. Is there something pricking our conscience when you say that it has come in a short period of time? And then during the pandemic, shortening the time frame from basic research to bedside is crucial. It's important. We all know there is a pandemic. You cannot wait for 17 years. It has to come rapidly. But when you do such research, it's essential that there are certain ground rules to make it ethical. This is something which is highly essential. And you know that for this, there are the CHIM studies. You know that when the COVID epidemic came, to make it to the people, you all know what CHIM studies is, I think you all know. This is the controlled human infection model studies. Controlled. So what you do is in the COVID, you make a person infected with COVID. So this is controlled human infection model. There are many things to be seen in this. You have to justify it. You have to justify the thing, the risk is worth taking. And then the second thing is, you have to minimize the risk. When you infect it to people, the people should not get any side effect. Can any one of you suggest who are the best people to do CHIM studies in COVID? Can you suggest, what is the, do you know, any one of you know who are the best people to do the CHIM studies? And it has, people came out in Oxford, they came out with the solution that the best people to do CHIM studies are medical students. You know, and that too, female medical students. Why female medical students? Because the complication rate in women is much less than in men. So medical students, because they can know what is the risk involved. Many people who may join because there is money involved, but medical students, they are supposed to know what is the risk involved. And so medical students are the best people for CHIM studies. So this is an important thing that you have to, and they understand the risk. So, and another thing is that you have to pay them compensation. But some people, it should be made that people should not be attracted by this compensation for CHIM studies. They understand the risk and then come in. And professional volunteers are there, you know, that for studies. But we should discourage professional volunteerism in CHIM studies. And in developed economies, you know that for many of the translational research, developed economies are looking into the developing countries for this. And it's sad that, you know, I don't know whether you can read the Indian sitting ducks for drug trials as drug trials run fatal. Many people are rushing to India. Why? Because it's very cheap. You can do the studies at 1/20 the cost in US. And then we have got a well-developed IT technology. Our doctors speak English. And I think that, and our people don't complain. So many of these people come out to us to do drug trials. And it is not, they may offer us a trip to Singapore or a trip to somewhere, but I think we should know the actual reasons behind it. And then before we accept this translational research, we should know what their actual indications are. But you should know that thing. No, this is something which happens. The big pharma giving the politician, they say that we can always blame China and get away with it. There is, I think that today morning Dr. Rajmohan said that we are studying academic discussion. This is not a political discussion. You may all know that there is a discussion about whether our intervention towards the dog menace is directed because of the influence of pharmaceutical making vaccines. But I think this is, the penumbra of translation research tends to incorporate tight financial constraints, connections between sponsors, scientists, clinical investigators, and also animal activists. Are there financial constraints which use that? Let us come out, let us find out, and come out in the open and say that this is not there or this is there. What is the harm in hiding it and saying that these people are not involved? If the vaccine pharma are involved in making us do this policy, it is for us to show that, look, we are not interested in we are not getting anything from the farmers. It is for us to show the public that we are not getting it from the farmers. It is for us to say that thing. In this aspect, translation research that raise some serious ethical challenges. Something that we should know is that translation research aims to translate the results of basic research to improve health. You know about one of the tragedies that occurred in translational research. I think many of you might have heard the story of Jesse, 20 years old, who died. He had ornithine transcarbamylase deficiency. The investigator was trying to put this carbamylase through gene transfer attached to an adenovirus. It was presumed that when you inject it into the person, it will go to his liver, improve his transcarbamylase levels. But what happened is that this adenovirus became virulent. He developed jaundice, respiratory failure, and he died. So I think in translational research, this is one thing, that safety issues are there. The special risks are there. Exploitation of the poor. I told you about the people coming to India to do research. You poor people are, and for what? For what questionable benefit? What do you want to risk our life for a transcarbamylase deficiency which occurs in about 1 per 100,000 people in the US? Why should we risk our lives? It has questionable benefits. Many of these are questionable benefits. This is another thing that, and the disparity between the And many of the things for which we are taken as study subjects are not at all issues in our country. So this is the big disparity that we should talk about. And uninformed consent, this is another important thing. When Jesse G. Singer was called for the research, he was not told that one of the recipients developed cold and then he had fever and things like that, because if he had known about it, he would not have participated in this. So we give them a consent in which we want them to participate, so we ask them, just sign here. And so it's many a time it's an uninformed consent. And coming to and this is the Translational Research Center at Penn. We heard about debates, we heard in the morning that about 20 crore translation as religious center is coming out in Kerala. I think it is a very, very important but very difficult thing that we are entering into. If you are let's say, the director of this Center of Translation Research, will you be able to show something that I did something in 1 year, I did something in 2 years? Will you be able to show that? I don't know, sitting in Trivandrum or in Kerala, if there is a Translation Research Center, will you be able to show how research has been translated into practice by the research done by us? I have my own doubts. But I end with a quotation from Leonardo da Vinci, who said that, I have been impressed with the urgency of doing. Yes, we should all do research. Knowing is not enough. We must apply. Yes, we should put it into practice. Being willing is not enough. We must do. So that's it. Thank you for the patient hearing. Thank you.
So thank you very much, sir, for the excellent presentation, as using his usual style of presenting with a sense of humor, so that I think all of you are hearing properly and not sleeping. And ethics, we know it is when a person starts thinking about doing a research, the ethical principles, ethics starts from there. But he has thrown light into some of the important areas which we were not giving much importance, or the unlighted areas of the research. Thank you very much, sir, for the presentation. Now, if anything need to be clarified, it is open for discussion.
Dr. Hindu, what do you think is setting the priorities for COVID menace? No, not the COVID, the dog menace. Are we having our questions right? Are we asking the right questions?
Sir, as you showed, it's a real question. I mean, we do not have the exact answer. One is that we lack the expertise from the animal husbandry side, what to do with the stray dogs. If we start vaccinating the stray dogs, the total number of dog bites will not come down. I think that simple logic is enough. Even the vaccinated dogs might continue to bite. So the number of bites, if that has to come down, definitely the number of dogs have to come down. But from the other side, so that area, we need scientific, technically sound answers from the veterinary side. What has to be done really on this? And the data that is available, there's a definite increase in the number of dog bites. There is a definite increase in the number of category 3 bites. And from the veterinary side, the data available to us and known to us is that they test the animals which are suspected rabies, mostly owned dogs, but there is a huge increase in the proportion of rabies among the animals who are killed, suspecting rabies. So that shows that the overall prevalence is on the increase. So as you have rightly showed, we need to ask the right question. Definitely there are several other answers on the choice, whether we should go for a pre-exposure prophylaxis, the cost effectiveness. So those are the areas, and availability, vaccine, several. And the pharma industry, I'm not sure, sir. Because as people, I think there are many community medicine people who work, because in all medical colleges, the preventive clinics are run by the community. medicine. So there is a definite increase, and why there is an increase in rabies among animals, there might be other reasons, like during the COVID lockdowns, more animals from forest. But definitely there is a sylvatic cycle as well, mingling with the domestic animals, and the circulation in the community has gone up. Those are some of the explanations only, sir. We need policy decisions based on data. And for dog control, as Raman Gutis was mentioning in the morning, the 3 departments have to come together. Animal husbandry, LSGD and health. Health is right now at the receiving end, but to reduce the number of bites and animal rabies, the other. I think the Goan example also, like vaccinating dogs was one of their important strategies.
Please keep short. Thank you. We have 1 minute.
Yes. Yeah, so thank you very much, sir, for a very nice presentation. Since you talked about ethics, about publication, I also want to mention here, because there are a lot of students and young faculty members, is predatory journal, publication in predatory journals. Because many people prefer to publish in predatory journals because you can get published in 24 hours and then you don't have to pay like a huge amount of money. Journals will ask you for sending publication. But I think that is one we should discourage at university level. I think university and VC can make it a point that no paper should be published in such journals. And about rabies, I just want to ask one question is, all the 20 people who died had received full course of post-exposure prophylaxis. I don't know, that is what I read in newspaper. I think that is another issue which we need to think.
21 deaths so far, sir. 5 received the vaccine, 1 is partially vaccinated. 15 out of 21 are unvaccinated.
Thank you, sir. We are sorry we have to cut short the program because a lot of work need to be done itself. So we will winding up.
So now we have reaching the last session of today's workshop, this group activity and plenary theme. Identification of barriers in Kerala context and suggestion for research evidence translation to clinical and public health practice. So situation review and suggestions for the way forward in key priorities for research focusing on implementation barriers. The participants will be organized into 5 groups, and all delegates are assigned in different groups in the morning itself, and so all are requested to join the group in the respective group. If anybody is not assigned, you can join in any of the group as per your interest. The first group is requested to assemble in the stage, and others can form groups in different corners of the hall. The facilitators of the group activity are Professor Dr. Vijay Kumar, Dr. Salina Shah, and Dr. Biju George. And we have identified 5 priority areas. First is emerging and re-emerging infection focus on pandemic, chaired by Professor Dr. T.K. Suma and co-chaired by Dr. Indu P.S. Second is non-communicable disease including cancer, chaired by Dr. Bibin Gopal and co-chaired by Dr. Eliama Matthew. Third is health system issues and high out-of-pocket spending, chaired by Dr. A.S. Pradeep Kumar and co-chaired by Dr. Shinu K.S. Reproductive child health, chaired by Dr. V. Rajashekharan Naya and co-chaired by Dr. Sandeep K. And the last one is mental health, chaired by Dr. T.V. Anil Kumar and co-chaired by Dr. Vidhu Kumar. So, all the delegates are requested to assemble in the respective areas. Group members are kindly requested to adhere to the ground rules. So it is displayed. Kindly see to it. So the time allotted for the discussion is 45 minutes. So all are requested to reassemble after the discussion by 4:25 p.m. After that, there will be discussion. Thank you.
നമ്മളാരുമില്ല.
Dear delegates, the time is about to finish. All are requested to reassemble within 5 minutes. Attention please. All are requested to reassemble. It's about to begin the presentation soon. So I request Professor Dr. Rakhel and Dr. Bibin Gopal to chair the session. And each group is requested to present 5 minutes presentation from the discussion evolved.
Okay, very good afternoon, everyone. We will now collect for the plenary presentations of each of the groups. And as already explained, we'll have 5 minutes per presentation.
Yes, sir, 5 minutes. So I invite the first group, that is emerging and re-emerging
I think the
infections.
first group has
Focus
asked
on pandemic.
for a little delay. They're just finishing, so we can start with the second group.
Okay, so we can start with the non-communicable disease, including cancer.
So Dr. Raji Paul Madam is going to present for the second group. She is the professor of community medicine, Gogula Medical College, Trivandrum. She is involved in many other activities related to cancer prevention. She also is a part of the NGO Snehida. Over to you, Madam. Thank you.
Thank you, sir, for your kind introduction. I thank all group members who participated in the NCD group discussion. So we have come up with few recommendations. We had a lot to discuss, but we could come up with few recommendations. But we think that is relevant in the field of non-communicable diseases. So first we were discussing about the burden assessment. Even though we have multiple data studies available regarding prevalence, incidence of different kinds of non-communicable diseases, we do not have a proper burden assessment in Kerala, because sir was saying like we have different burden, we have just like different countries have different burden. In India we have different prevalence and incidence and different burden in different states. So it is very important, and inside Kerala also we have differences. So it is very important to have a very proper burden assessment, and that too we have something like a cancer registry, but that was not unanimously agreed. But we have, we should be having a proper burden assessment before we plan other interventions. That was one recommendation we had to put forward. The second one is the risk factors to focus. So NCDs, we all know we have most of the risk factors are common. So our intervention should focus on all risk factors together, and these interventions can be, and that was a third suggestion that we should be giving through these NCD risk factor focus should be, we should begin from the school level. So we recommend inclusion of primordial preventive measures and this kind of education in the school curriculum, so that we can have from the next generation, they'll have proper awareness regarding these kind of risk factors and how to prevent and what lifestyle modifications they have to make. So inclusion of NCD preventive measures in school curriculum, that is the third recommendation we had. And the fourth recommendation was enabling environment for lifestyle modification. That is a population approach. So we should be having proper walkways, that enabling environment, that we'll be continuing our discussion, and we can focus on each and every recommendation. So as a broad statement, it is an enabling environment for the prevention of non-communicable diseases. And the fifth point was we should be focusing on early detection and proper management. So early detection means it is very important, and that was discussed on about cancer. So it is very important to downstage the cancers, especially breast, cervix, and oral cancer. And these cancers can be detected early so that we can downstage the disease, and we can also reduce the mortality due to these diseases. So we should be focusing on early detection of these cancers, and we had programs for early detection of these 3 cancers. Now the trend, according to Eliamma Madam, it is changed. We also have increasing number of colorectal cancers. So the colorectal cancer has come to the top. That is the 3rd common cancer incidence in Kerala. So we have to focus on lifestyle modifications as well as tests that can have important in the early detection of colorectal cancer. And the test suggested was fecal immunohistochemistry test. So we have a proper early detection program for colorectal cancer as well. Then involvement of other systems of medicine as well as we should also come up with recommendations for the non-pharmacological interventions in non-communicable diseases. So we should be taking inputs from other systems of medicine, because we have, in the university, we have all systems of medicines combined together. And we all continue to discuss these areas, and the universities and research institutions can bring up with more recommendations, especially the group members who volunteer in the group are volunteered to continue the discussions, and we can come up with more relevant and systematic recommendations for the policy. That's what I think.
Thank you. Now I invite the other group, health system issues and high out-of-pocket spending. Speakers kindly note the time allotted is only 5 minutes.
Dr. Rekha is an assistant director in Kerala Health Services Department. Yamoli, okay. And she's a PhD holder in geriatrics, and she's now working as the researcher in SHSRC, the State Health Resource Center. Over to you, ma'am.
Am I audible? Oh, yeah. Okay. Thank you, sir, for that introduction. I represent the team health systems. The objective of our team was to identify gaps for research in health systems. So actually, our team consisted of representatives from health services, DME, then higher institutions like Achal Menon Center, then representatives from nursing education, pharmacy. So it was a heterogeneous group, and we had a great discussion, and we have identified 10 or more gaps that require immediate attention for the improvement of the health system. So the members actually reiterated the relevance of the major policy initiatives that have taken place in the over the years, and like from 2000 since 2003, from MGP, then 2005 NHM, NRHM came into existence. So there were a lot of resources coming in, I mean, as funds for training, HR, infrastructure development and all. So these initiatives, then later on in 2013, it was NHM with an urban component. Then in 2017, Ardram was introduced in the health system, involving all three levels of system. And with all these initiatives, actually, are we achieving the objectives we are planning? Whether we have achieved the universal healthcare? That was one question raised. Actually, we need to know, even though the latest statistic shows that there is an increase in the, I mean, in the number of the persons who are attending the public institutions, we would like to know whether are our public institutions meeting the demands of the public in this Kerala considering our epidemiological and demographic transition of our state. Are we meeting the demands for the public? Why? Naturally, a question will arise, like whether the public institutions cater for the needs of the public. So, with the, I mean, with the context of this increasing number of deaths due to rabies, we were discussing about the quality of vaccines, and also naturally a question was raised regarding the quality of supplies in the public health system. The supplies, not only the medicines, equipments, the institutions as such. Even we know that a lot of investment has gone for infrastructure development and I mean procuring the equipments and all. So we would like to know whether I mean it's meeting the quality standards. Then as I already mentioned, there are a lot of initiatives taken place, and the driving force may be international, national, or state level driving forces were there. Major initiatives taken place, national initiatives as well as state level initiatives. So we would like to know the current health system is the result of all these initiatives. So we would like to know what has really worked, what were the objectives of these initiatives over the years, and what has really worked, and we'll explore the reasons for that and what did not work. And these learnings would help us to, I mean, implement implement it in the coming initiatives as well. So that's one area identified. Then as already all of us know that decentralization, Kerala is one of the state with, I mean, with better decentralization in I mean inside. So at the local level, local institutions have a major role in I mean providing the health, I mean in shaping the health outcomes. So we would like to know the barriers of local level planning. So what's happening right now, and how is it, how can it be made more effective? So, so that will be another area. Then naturally one of the, I mean, Ardra mission was one major initiative that, I mean, a lot of resources has gone into it. So we'd like to know the learnings of Ardram phase 1. How did it, I mean, what all was all the against the objectives of Ardram phase 1? Kind of evaluation in all levels of care. Again, we know the out-of-pocket expenditure is high in state of Kerala. So we have a lot of insurance schemes and in place. So we would like to know the impact of the welfare schemes that has come into existence. Then also there are a lot of initiatives like to reduce the out-of-pocket expenditure of the public. Karunya, Nidhi, Jan Aushadhi, several initiatives like this. So nobody has looked into, okay.
Excuse me, time is over.
Yeah, one more minute. I'll take 1 more minute. So this initiative, to evaluate these initiatives and to come up with solutions. I mean, whether they were useful or not. That's one area. Then one process that's ongoing, like competency mapping of different category of staff in the primary care. So that can be escalated to other levels as well. And we'll come up with the training needs of different category of staff in the health system to cater to the public in the context of the emerging needs of the people. So this was one area. And the last but not least, we have several legislations with regard to public health. There are a lot of barriers in enforcing it in all levels, like even formulating the Public Health Act, Unified Public Health Act, even for that we are facing challenges. So we would like to explore the reason for this and how to come up with healthy
reproductive child health.
Okay, thank you.
Professor Rajeshwari sir needs no introduction. He is considered to be one of the pioneers in the gynecological field. He is also the previous president of the KFOG. So welcome, sir.
Respected chairpersons, Professor Rajmohan, senior faculty members, my dear colleagues and friends. I think only 3 of us are there in the group. We have put our head together and identified certain points which may be relevant to for carrying on further discussions. Basically, if you look at the SDG goals, we are expected to reduce the maternal mortality ratio below 70. But we find that already we have reached a stage in which the MMR for Kerala is 30. Actually, we are way ahead with other states. In fact, we could achieve this low MMR due to a collaborative effort between our federation as well as the government. Dr. Vipin and his colleagues liberally help us in Dr. Jagadish also is there. All of the staff members in the health department, they help us in pooling the result data, and we do an analysis on a confidential basis. Probably this is a unique system which is there only in Kerala. And in few other countries, UK, Singapore, South Africa, these are only the limited situations where confidential review is in place, and we are able to continue with this from 2003 onwards. And periodically, we come out with publications which give recommendation to the practicing professional as well as for the policy makers to modify certain ground realities. And our initial investigations revealed that whenever there is a maternal death, on 75% occasion, it is due to a poor quality of service. And system factors such as absence of bed or there is no ambulance or no blood, such situations are extremely rare. So basically, we looked at improving the quality from the initial period onwards. And this is the result for the last 10 years. In fact, the lowest, that is the lowermost graph, the hemorrhage is number one killer, just like any other situation. But in most of the other Indian states, it is almost 30, 34%, etc. So the percentage we are not able to reduce much, but the number of deaths has drastically come down. Hypertensive disorders, all these things. And a recent phenomenon is that we are seeing that a lot of deaths due to suicides are happening. In fact, when you started the study, it was less than 1%. Every year we find that it is increasing, and maybe we may have to go in for special strategies. Basically, we were trying to look at the quality and improving the quality of services, but I think recently we have realized that we have to alter our approach to this particular problem. We have reported this to the government. In fact, there are several programs such as the Ammanas and all those things where screening is done to detect these labile personalities from the early pregnancy onwards. In fact, initially we thought that it may be due to what is called the postpartum blues, the so-called postpartum depression. But on further analysis, we find that it is not postpartum women who are developing this particular problem. It is actually, in most of these cases, are in early pregnancy. And it's a fact that other social factors are operating. Dowry-related deaths are there. So many things are there. I think a detailed study, and we have to alter. We are thinking in terms of including other strategies also. Probably a social scientist should be there, and maybe a complete relook at this particular problem. Okay, so the conventional CRMD failed to identify, actually failed to address this issue, and we are looking at identifying special strategies. Then recently we have hit upon other thing. As I have already shown that PPH is the number one killer. But there is a simple technology that is, instead of distending the uterus with the balloon tamponade, etc., a simple suction cannula. And two of our colleagues in Kerala have devised these things. And this simple suction method could drastically reduce the incidence of PPH-related deaths. And we are just going to popularize this particular technique. This is one such one model. There is the Panikad's cannula. Then there is another thing, that's the Samartharam cannula. So a simple technology then can bring down deaths. Then similarly, Dr. Paili, my senior colleague, he has devised certain clamps, even the aortic clamp, etc., which can be used in certain desperate situations. So we are utilizing this indigenous technology, and we have just yesterday we met the health minister, and she has promised that all these things will be put into practice within a very short time. Then, as all of you know, the lifestyle diseases are on the increase. Overweight, nearly 30% of children are obese. Then we get a lot of pregnant women with mild anemia, if you look at the WHO definition, okay? And it is very difficult to correct it during pregnancy. So I think we may have to look at this specific problem. For example, we'll have to focus on boys and girls during the...
Excuse me, sir, time is over.
Yeah. Just 2 points. I will rush through that. Then another thing is that nearly 70% of deliveries in Kerala are happening in private sector. So if you bring in reforms in the government sector alone, we are not able to reduce the MMR. So I think we should have more inclusive governmental policies. And maybe I think you can you can change this government policy, and we can even think of a state-specific modifications of central government team. For example, the PNDT Act is a redundant act as far as the Kerala scenario is concerned, because almost all the abortions are medical abortions. So nobody can do a sex determination prior to such things. Okay. Then it is high time that we look at the third entity, that is, most of our deaths are happening due to delay in getting adequate care, not due to the delay in seeking care or delay in reaching facility. So the deadly in-hospital delays continue to be the major problem with us. So we'll have to specifically look into that also. Then congenital anomalies, preterm labor and congenital anomalies is a major thing for neonatal deaths. And the standard anomaly scans are done at 13 weeks, 11 to 13 and 19 weeks. But in fact, the cardiac development is complete by 23, 24 weeks, etc. It may be difficult to detect by the standards. But even then, we are able to offer a termination if the gross anomalies. In fact, those anomalies would have been detected much earlier, but we do not have the required number of expert zonologists. I think we'll have to look into this specific problem. Then out-of-pocket spending also becomes very high in such situation. So these are the few things which we have I had to highlight, and my pediatric colleague, Dr. Geeta, she will be continuing with the discussions. Thank you.
Thank you, sir. Next group is mental health group.
Under 5 mortality. Full screen. So the topic given to us was reproductive and child health. I am Dr. Priya from pediatrics. I'll be dealing with the how to reduce the under 5 mortality rate. So regarding the situation review, you can see that different data gives different values. So that is one big problem. In NFHS, the value is 49, whereas in UNICEF it is 41. And again, the 2020, that is the latest data, it says that NFHS 5, that is 41.9. And the Kerala, it is 5.2. And in this is the trend, which clearly shows that there is a reduction. And are we different? The global data says that the under 5 mortality is 37. The highest is from Nigeria, that is 117. And our neighboring states, Pakistan, it is 67. And, but Nigeria and India alone account for almost 1/3. And here now, this is very important. That is the global burden of the disease study, which says that in 2017, it is mostly the newborn causes that cause almost 38 to 40% of under 5 deaths is because of the newborn causes. And then you have the acute respiratory infections, diarrhea, and in Kerala, what is more important is the congenital birth defects. And these are the SDG goals, that is reduce the neonatal mortality rate to 12, and in India it is 24, and to reduce the under 5 mortality rate to 25, in India it is 41.9. Now, these are the non-interventions that work, that is address the causes of different, this neonatal mortality, that is prematurity, asphyxia, sepsis, then vaccination. And we should know that in Kerala, the fully vaccinated, the percentage is only 85. And the wash techniques have to be promoted, prevention and control of pneumonia and diarrhea. And here we should know that in India, only 56% they seek care for acute respiratory infection. For ORS, they get ORS, it is only 60%. And zinc, the number who get it is only 30%. And reduction of household air pollution, HIV prevention, and prevention and treatment of malaria and measles. And malnutrition is said to be an indirect cause. That is 30% of under 5 deaths, the children are malnourished. And we should know that in Kerala, the wasting percentage is 15%, severe wasting is 5.8, stunting it is 23.4, anemia it is around 40%. And exclusive breastfeeding till 6 months is only 55.5% in Kerala. And in complementary feeding starting at 6 months, it is only 70% in Kerala. Vitamin A supplementation, again, it is only 85% in Kerala. So we have a lot more to go. So these are our recommendations. Focus on the newborn services, that is the antenatal care, antenatal scans, because neonatal issues are important. Newborn screening, that is to identify the birth defects as much as possible. And NICU services should be strengthened. And NRP, that is the resuscitation programs, should have to be taught. The training programs has to be strengthened. And we have our new MCP card, that is the Mother and Child Protection Card, which came out in 2018. It is actually a very good tool, but it is not being utilized. Actually, the private sector is not having this MCP card. The government MCP card, it has got around 45 pages. It has a new growth chart. That is it can identify wasting also, the weight for height chart. So that growth chart has to be used for early identification of malnutrition. Then the healthcare worker as well as the mother should be taught about this MCP card. And you have to strengthen the IYCF practices, infant and young child nutrition practices. The routine immunization should be strengthened. Again, it is more of private-public partnership. The living conditions have to be improved. Then you have to ensure child safety. That is, you have to give anticipatory guidance regarding the accidents, poisonings, all these things, because these under fives, there are more chance for these kind of accidents. So these things you have to teach the parents. And our association, Indian Academy of Pediatrics, have put forward a parents' trust questionnaire. It has got a very simple 4 questions you can ask and find out if the parent is having any stress. And it has been found that these parents, if they are stressed, it can lead to under 5 morbidity. So, and you have to revamp the programs, that is ARI control program, ADD control program, Anemia Mukt Bharat, because during this COVID season, this Anemia Mukt Bharat, this program is not being implemented.
Excuse me, the time is over.
Okay, I'll take only 2 minutes. Vitamin A supplementation, the Hridyam program, because these congenital birth defects, the heart defects and all will be corrected in Hridyam. And vitamin D and vitamin K is being given. Till one year you have to give vitamin D, but government has to take it up as a program. You have to focus on the special groups, that is the infants, tribal settlements, the Attapadi, migrants, we have a lot of migrants. Then rare diseases, because again it is the birth defects that is causing the problem. So the genetics, rare diseases, inborn error of metabolism. And lastly, we have to collect the data, we have to evaluate action based on this, and then re-evaluation and updation of all these programs. Thank you.
Now the next group, mental health group.
Same pen drive. Madam, വരുന്നില്ല.
Good evening, everyone. In our group, we had a brief discussion on the current scenario, the existing programs. In our discussion, we came to know that many of our programs are running based on a solid research base. However, few are in a mission mode. And based on our discussion, we arrived at few suggestions. I'm presenting in brief
Can you
the
introduce
suggestions.
yourself first? Can you introduce yourself?
Yeah, I'm Dr. Tinku Wilson. I'm a psychiatrist currently working in health services. I'm right now doing MPhil clinical epidemiology in School of Public Health. So here are our suggestions for regarding addiction, screening and brief intervention for substance use disorder by primary care physician. Actually, brief intervention for substance use disorder is based on WHO model, which has a clear evidence base. Brief intervention for substance use disorder means if a patient come to you, come to any doctor who is working in a primary care setting with a gastritis or maybe any physical symptom, and he gives you a history of substance use, we can just talk to the patient and prime the patient regarding the importance of getting treated for substance use. We can talk to the patient about the gastritis and just hint the patient about the problems the substance can cause and motivate the patient for de-addiction. That's the brief intervention. This could be extended to any setting, including jails, juvenile homes, where it applies. And regarding children, behavioral and emotional problems in children, behavioral addiction to be screened as part of school mental health program for early identification and intervention. And for women, Programs like Bhumiga to address domestic violence to be strengthened and to be integrated with primary healthcare system. And for elderly, mental health care of elderly to be integrated into Vayomitram and palliative care programs, and duplication of services have to be avoided. And programs like Young Old, taking care of old, integrating elderly care with ICDS program, and online provision of care for elderly by trained volunteers. And about suicide, which is a very important problem we are facing now. All suicides and attempted suicides have to be reported to healthcare delivery system for proper evaluation and management, including preventive care. Live Life, which is a WHO program to counter suicide, to be implemented. Live Life work through 4 steps. Limit access to the ways to do suicide, and interact with media for responsible reporting, foster social and emotional skills in adolescents, and early identification and treatment. And addressing post-COVID mental health issues like depression, anxiety, insomnia, cognitive symptoms, warning signs of suicide to be evaluated in all patients attending post-COVID clinics. Evaluation of existing programs like DMHP and its targeted interventions like Sambhurna Manasik Arogyam, Ashwas, Jeeva Raksha, School Mental Health, Amma Manasa, program evaluation by an independent agency, and strengthening of the same. Last suggestion is integration of mental health, including positive mental health, has to be integrated into primary healthcare system through the proposed Health and Wellness Center. Thank you.
Thank you. Now the last group, emerging and re-emerging infections, infection focus on pandemic.
Dr. Tony needs no introduction. He's a part of the medical faculty in the community medical medicine department, Medical College Trivandrum.
Respected chairpersons, I apologize for not following the order we had. We needed 2-3 minutes more. There's only 4-5 slides. I thank all my group participants, my chair, Suma Madam, co-chair Indu PS Madam. We had eminent personalities from general medicine, emergency medicine, community medicine, pharmacology, and even from the health services. So we were given a task, and the methodology was, our topic was emerging and re-emerging infections, focus on pandemics. And the methodology we followed was listing of diseases. There were 16 participants, and we listed all the infectious diseases. Then prioritized listing of the diseases was done using voting. The prioritization was based on voting. And then for each, there were 9 elements or 9 criteria. For each criteria, we had given a weightage. The weightage ranged from 1 to 2. 2 is double. And then scoring for each of those elements. The minimum was 0 and the maximum was 10. And the score into the weightage was multiplied to give a final total value. And the assessment was done. That is, the performance of the prioritization was done, and selection, that is the ranking of the diseases, and we came to our recommendations. So the results, the priority diseases identified in the group work are dengue, avian influenza, leptospirosis, Nipah, and tuberculosis. This is in the Kerala context. diseases of potential large outbreak. Now coming to the recommendations, we divided into general recommendations and specific recommendations. In the general recommendations, we are suggesting strengthening surveillance, interdepartmental coordination and sharing of information, early detection of outbreaks, community reporting and exchange of data. This is very, very important. Surveillance is the key or the primary thing for prevention and control of diseases. Supported by laboratory capacity, it's strengthening as well as decentralization. Health awareness, healthcare worker and the community, very, very important. Healthcare worker training, IPC, infection prevention and control strengthening, availability of medicines, public health coordination center and health system resilience is also very, very important. We have seen in past few epidemics. And the cornerstone is One Health, animal, human, and environment. All things go together. Coming to the disease-specific recommendations, dengue prevention and control, strengthening of surveillance, early detection, clinical management, preparedness activities, that is pre-monsoon activities, early detection of hemorrhagic and other complications and capacity development. Early detection of hemorrhagic is very important to prevent mortality. We can prevent we can identify plasma leakage early, very early, and prevent. Avian influenza, early detection, surveillance, intersectoral coordination, and public awareness. Alappuzha district has already demonstrated that, but we need to scale that up to other diseases and other districts. Leptospirosis, major cause of mortality among the communicable diseases in Kerala. Early detection, protective measures for high-risk people, health awareness, animal vector control measures, intersectoral coordination, waste management. And the next is NEPA, early detection, laboratory measures, IPC strengthening, clinical management, antiviral drugs, antiviral drugs and materials and their stockpiles for management of outbreaks, epidemics, and potential vaccine development. Number 5, tuberculosis, strengthen the national tuberculosis elimination program strategies, detection through identification of latent TB, newer rapid diagnostics and control measures. So these are our specific recommendations, and I thank the organizers for this opportunity.
Thank you.
Just one question to Dr. Tony.
Yes, sir.
How did leptospirosis come down in priority?
Sir, the group were of the view that leptospirosis causes major mortality. But in a large outbreak potential, a pandemic potential, which strains the health system and human-to-human transmissibility, in those indicators, it has come down, sir. That is how it has come. I'll just show you the, these were the indicators. Actually, these were the indicators we gave, like human transmissibility, severity. These are not numbers, actual numbers. Case fatality, spillover, evolution and potential, available countermeasures, difficulty of detection, all those things. So it's a matrix that we worked out. Yes. Thank you, sir. That's
Okay, thanks very much for all the groups, and thanks for attempting to keep to time. This has obviously been a very rich discussion, and I do hope that all the groups will, I think, provide their suggestions in writing so they can all feed towards the final report of this program. So thank you very much for this.
If anybody wants to say something, we will wait. Otherwise, in spite of the hartal and travel restrictions, everybody has come, and it is a great inspiration for all of us. Actually, the Directorate of Health Services, Directorate of Medical Education, and University has together organized this. I think it is actually a very good success story of collaborative effect, and we all work together. That togetherness is very important. Tomorrow we start at 10 a.m. 9 a.m. And tomorrow I expect more people because Hartal is not there. But we have arranged everything. Tomorrow morning there are presentations. First is on epidemiology of COVID, then on impact of COVID on health science education, then care and support in the community, and thereafter in the afternoon sessions, there will be clinical sessions like critical management of COVID, guideline review, then post-COVID syndromes like respiratory, cardiovascular, and neurological. We may have a wrap-up. Kindly involve, and please, this is actually, it is a long effort we have been working. Madam Indu and Senior and group has made some effort on vaccines. Care and support LSC, Dr. Jagajeevan has worked, and health science education, Dr. Iqbal will be presenting. So it will be definitely an academically sumptuous feast. So please contribute, involve, and make some output for our thought stimulation and continuation tomorrow also. Thank you very much. Any other comments? Indu, you want to say something? Thank you very much. Okay. Please help each other. I think after 6 the Hartal will be over. You may get vehicles. If there is any difficulty for somebody to reach homes, please help each other. You want my help? Definitely.